And good morning, everyone. How are you? Good morning, Tammy Sparacino. It's nice to see you. Welcome to PerfWeb. It's been busy for all of us, and we're trying to make some last-minute adjustments. Of course, we have a really, I hope, really good show for you today in our efforts to continue and try and evolve. I may as well just tell you now, I think you saw it on the advertisement. It's the first installment of the Vanderbilt University Department of Cardiovascular Medicine Faculty Forum with Matt Warhoover as the director of the program, of course, and with Joey Lepore, who is one of his top colleagues over there. Forgive me for that. But they're having some technical difficulty on their end getting signed in here so that we can bring this. So we started this whole idea. We're going to have studios in different places. Vanderbilt, who had worked with us once before, was the first to step up, which we're so grateful that they did. But we got to get them up and operational. So in the meantime, I'll do my normal. Can I do, David, would it be okay if I just did my normal opening remarks? Do you want me to go ahead and do that? Okay, so I can do that. So I'll do my normal opening remarks.
Camera 3.
Camera 3, that's that one. Thank you, Tammy. Thank you, Tammy. So, our project, of course, of doing these educational programs is really to try and bring high quality, relevant information to you, our clinical colleagues, so that you can, use it in your practice. Now we're more clinical, I think, in our approach towards things rather than, I would use the term, I guess, academic. We don't necessarily just pick apart data, but we talk about clinical experiences, which I think is very important. But anyway,
I'm calling them right now, just to let you know.
Oh, good. We're calling over to Vandy right now. So, do you want me to drop this now and just go to you, or what are you going to do?
You can go. I can push.
Keep going. Okay. So let's do this. Our social media, please, 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 please go to YouTube, go to Facebook, go to the Twitter. Share us, like us, follow us, give us the thumbs up, subscribe to our channels. It's really important that you do this. It helps us more than anything else does. So we appreciate that. Go to our two websites, perfweb.us and perfusioneducation.com. So perfweb.us is our schedule. You want to know what we're going to do through 2054, just look on perfweb.us. If you want to become a member of our educational platform, which is free, go to perfusioneducation.com. Now, both of those will get you back and forth, so there's links all throughout that. And please excuse me. There's links all around that. However, perfusioneducation.com, again, is free. Membership is free. Would appreciate you being a member. We'll send you emails now and again that will tell you about some exciting things that we're doing. Which camera am I supposed to look at? That one?
3.
Okay. And we'll go from there. Our contact number comes up. Please call us live. Be on the air with us. Would love to have you. The MediWeb app. Don't know if I want to show you that right now. Do we?
Seems like we might.
We're going to do that? We can at least show you the thing. And it came in handy for me yesterday. Everybody was asking me, I was transporting an ECMO, and they said, do you need a new tank? And I said, no, I've got 162 minutes of time left in this tank as it is. How do you know that? And I pulled out my MediWeb app, and I went to ECMO, and I went to time remaining in E-cylinder and showed them. I sold 5 apps. Sold 5 apps. So it's $2.99, okay? It's $2.99. And you get so much. You have perfusion with Perfusion Quick Calcs. We'll demonstrate it another day. But you get ECMO, you have conversions, you have clinical calculators, you have an IV drug and drip app within that app, which is actually sold separately for 99 cents for nurses. But if you work at the critical care unit, you want this app, okay? It's $2.99. We're going to be doing a release of an update soon, Magic, I hope, with those additional things. So we're going to continue to evolve it and make it really good. We have a new podcast. You can go to Podbean. You can go, is it Podbean or Podbeam? Podbean, okay. And Apple Podcasts, Google Podcasts, Spotify, really anywhere you listen to podcasts, whatever your favorite streaming station is. And with that said, don't forget, next week starts our spring conference, April 14th through the 17th.
Yep.
It is going to be awesome. It is going to be an awesome conference. It really is. I'm excited about it. And are we ready?
No, we still having some difficulties.
How much? Okay. Still more difficulties? Okay. So you and I can talk. So what do you think, Tammy? How's everything going in COVID world?
Well, it's slowed down some, but we're still fairly busy with it. You did a transport yesterday, not COVID, though. Yeah.
This is true.
Yeah. There's
This
still
is true.
ECMOs out there that aren't COVID.
So you want to talk about, look, I see them. Do you want to talk about, real quickly our 2 patients who are now extubated on ECMO?
Well, sure.
Go
Go
ahead.
ahead. I haven't been there since they've been extubated. That's all about you.
Neither have I.
Oh. Well, we have 2 patients that are on ECMO.
I haven't seen them either.
And
But they stood one of them up,
yes.
and he has a BMI of 62.
Yes.
I was very concerned.
And they're both awake.
Yes.
One of them's kind of chatty.
Yeah.
I don't know.
I think it's just amazing.
It is
It's
amazing.
just
I can't wait to get out there and see them.
Me either.
Yeah.
Do I see Dr. Hoffman there too? There's Joey. There's Dr. Hoffman. Hey, guys, are they ready? They hear us. Hey, Matt.
Good morning, everyone.
Are you able to hear us?
I can now.
Perfect.
Okay, so with that said, finally, it is with, so which camera are we looking at here? David?
Camera 2.
This is like the Keystone Cops. Why don't we go to camera 1?
You can't when you share slides from somewhere else. It has to be camera 2.
No, he can. Yeah. Okay. So it's really with great pride. I'll just do this to be doing the inaugural Vanderbilt University Medical Center Department of Cardiovascular Surgery Faculty Forum. And Matt Warhoover, thank you so very much, the director of the program, of the perfusion program. I can't thank you enough for doing this. You've participated in our programs before. With you, of course, is your colleague, Joey Lepore. Joey, good morning. Thank you so much. I know. Do you go by Tony or Joey?
I go by Joey.
Joey, okay. But your name is Anthony.
Yeah, my mom wanted to make it complicated for me.
I understand that. And then there's Dr. Jordan Hoffman, who is I don't want to get this wrong, but you're not you have a chair of Department of Surgery, Cardiac Surgery. Are you you're the director of the program or the chairman of the program, Doc?
I just exist.
I understand that. Okay. You do I understand that. When we were out there visiting you, we were going to go to dinner, but you had to leave and fly down, I think it was down to Duke, to go pick from Vanderbilt to go pick up a heart and lung and block, I think.
Yeah, that was a heart-lung procurement.
How did that patient do?
Well.
Good. I'm glad.
He didn't get the heart-lung from that particular donor, but the following day or 2 days later, we got another offer, and I procured that, and he got transplanted, did well, left the unit, and is almost out of the hospital.
Wow.
That is absolutely fantastic. I'm so happy about that. So, Matt, once again, I want to thank you. We've worked on this for quite some time to start expanding what is really the knowledge pool to get enough people in the various parts of the country and hopefully the world to participate in this and everybody have a perspective and see what our collective knowledge is. So thanks for being my friend. Thanks for taking us to dinner that night. I really appreciate it. I don't have very many friends, Matt, so, hey, everyone I can get, I appreciate. And you're going to be talking today on this inaugural program on DCD, which is the first time I'd ever heard of it, was talking to you, which is heart procurement, which is donation after cardiac death, and using the Transmedics device as an organ care system. You are one of the very few that have the opportunity to work with this device, and I think that all of your knowledge, and plus you were #1 in heart transplants. I forgot to mention that just recently, which I thought was so important. But I think you guys have a very unique perspective on all of this. Looking forward to the talk and the short discussions afterwards. So with that said, I've talked long enough for my till I have my sip of my coffee. It's on you, Matt. Floor's yours.
Appreciate it, Joe. Thanks for having us. We're excited to be a part of this, and hopefully this continues to be an ongoing program for us, kind of be able to kind of collaborate across this new Zoom world that we're living in. So without further ado, we can just jump into it. I'm going to go over the overview of the Transmedics OCS organ care system, and then Joey's going to talk about more or less a one-off what we've done. We've kind of created our own system, if you will. And he'll get to the details after my short little slide. So we'll just get into it. Next slide. So DCD, as you talked about, Joe, it is a donation after cardiac death. Essentially what it is, it's the donor is not considered brain dead by the definitions, the medical definitions. And so what has to happen is that they actually withdraw care. The patient expires naturally, and then after the patient expires with from a cardiac standpoint, asystole or PEA, depending on who's declaring, then we're able to harvest organs afterwards. The DCD is not new. It's been around for over 40 years. In fact, that was the very first donations. That's because they didn't have the test to determine brain death at that time. But they've been doing donations like this for a long time. Ironically, these organs would simply just be going in the trash. I don't mean trash, but they would really be not utilized, and they would stay within the patients. They would expire, and they would go to the morgue or wherever it was. And there's not enough organs out there. There's a long list, as you all know, and we have the ability to increase about 25% of our organ recovery efforts. Next slide. So these are all the organs that are currently utilized in DCD. We see quite a bit with the livers and the pancreas and the kidneys. The abdominal teams are quite aggressive, and they probably make up the lion's share of all DCDs done across the country, probably upwards of 4 times of the number of hearts that are done. And so but we're starting to expand in this field and trying to get a foothold because hearts are needed just as bad as any other organ. And then the lungs, although we don't do the lungs currently with the OCS, lungs are able to be pumped on the OCS with a different disposable, as are the hearts and the livers. It just takes different disposables, but the hardware is the same. It's just the disposable that changes. Next slide. And so how it goes about is that the family has decided that they're convinced that this is what their wishes or their loved ones' wishes would be. And although they're not technically, by medical definition, they don't meet the requirement of brain dead, they feel that the quality of life is not going to be there for that patient. So they consent to the appropriate removal of the support, and then the OPO decides to deem them as appropriate candidate, and then they send out the offers. What is very interesting is that patient, until they expire, they're considered a patient, and there's very, very strict ethical safeguards for those patients. The procuring physicians and personnel are not able to actually be in the room or take care of the patient until they've expired, and therefore they're no longer a patient. Then the procuring team can actually touch the body. We're never part of the decision making of how that patient is taken care of, and it's kind of a hands off. And really, you're really wanting to be blinded to it because you don't want to influence that. They really want to keep it a separate church and state. That patient is being cared for by that facility, by that team member, and all the physicians from that hospital. And we're coming in as the secondary team that really takes over after death. Next slide. So these are our potential donors. It's a myriad of different etiologies, but typically it's some sort of head trauma or anoxic injury. They cannot usually overbreathe the vent, but yet they still don't meet that criteria like we talked about. And we have a criteria. Joey's going to talk about that in a little more detail. But usually we need the patient to expire within about 30 minutes of withdrawal support. Next slide. And then our criteria is, the criteria for the DCD for the OCS is a lot more stringent because of the rules and regulations surrounding the FDA and different of the trials that are going on. So 18 to 49 is the age for the patients that are donating. We have to have a crit of greater than 25%. If the crit is lower than that, they will transfuse up to that, and we usually get a blood gas within 30 minutes of extubation. And so what happens is that once they withdraw support from the ventilator, the patient will start to deteriorate, and as soon as an arterial saturation hits 70 or below, or the systolic arterial pressure is 50 or below, that's when our clock starts. And so depending on where we're at, institution to institution and state to state, sometimes there's a 2-minute standoff period, sometimes there's a 5-minute standoff period. So what that means is once the patient does expire, they will declare that they have death, and then they will use a stethoscope, and they'll listen for heart tones and what different signs. 2 minutes or 5 minutes later, no one can touch the patient during that time. And once that standoff period is done, the physician that was taking care of the patient will check for vitals one more time, and at that point they're declared, they've passed. And then that is when our team can actually start the process. The patient is expired. It's no longer in the care of that physician or that hospital, and then we're going to start taking over. It's kind of rough to say, but we're going to start managing the organs that are still available there that are left on the table. Next slide. And then this is a slide I took from Transmedics, and it just goes through the procurement process. I could talk about it, but it essentially really does a good job of what the process is and how it works. Starts out with withdrawal, then we go to the timer, and then it goes into we create the cessation of circulation. It's declared by the physician, and then the observation, the standoff period. We get into the pronunciation of death, and then we go ahead and we reanimate the heart and get it on the OCS. Next slide. And then the OCS really does act like a miniature intensive care. We're watching the parameters. We're watching the blood pressure in the coronaries. We're watching the flows out of the coronaries into the coronary sinus. We're watching lactate levels and all your blood gases that you would normally run a full panel. And we try to mimic the natural state of the body. We are able to even hook up a hemoconcentrator if possible, if we need to take some volume off. More than likely, we usually don't ever get enough volume. And Joey's going to talk about the details of how we procure more or less the finer points of that in his slide. But like I said earlier, the OCS, liver, heart, and lung, they have the different disposables. And that's pretty much the overview of what the whole DCD process is. OCS is very specific. We're using their device. We're using their trials, their recommendations. And so the framework is a little bit tighter as far as what the donor criteria is and the parameters in which you accept the heart or you don't accept the heart after you put it on the OCS device. But ultimately, it's up to the transplanting surgeon, back here at Vandy, whether we take the heart or not. After 2, 3, 4 hours, up to I think we've done it up to 6 or 7 hours on the heart in a box, and then we just watch the heart, run the labs, and see if it's a viable organ that they're willing to place in our recipient. I think that's all I got. Next slide.
I think that's it.
Yep.
Hey guys,
Hey.
that's fascinating.
Really is.
What I first learned about all of this, but I've heard rumors of, but really learned about it talking with you, Matt. But it's an amazing device. Do we want to get into these discussions now, or do you want to go forward with Joey's presentation? Does Dr. Hoffman have something he wants to add to this prior to us going on to the next thing, or just tell me how we need to run it?
I think it'd be better to see the next presentation so that when we discuss the different issues surrounding DCD donation, we can reference both talks, both techniques.
Sounds good.
Perfect. Okay, so can we do that, guys? David? There you go.
All right. Well, once again, I just want to say thank you to Joe for having us on. We appreciate the collaboration here. I'll do a brief discussion on we call it NRP, but as you see here, normothermic regional perfusion. Essentially, is in situ or in the body, procurement of the heart. So if you want to begin, go to the next slide. So really what we've done is we've taken what we've learned from the ex vivo organ procurement, with the OCS, and we've applied it to, the kind of the traditional way of procuring hearts, and it's allowed us to expand our offers. Again, as Matt alluded to, we have such need for organs, and if we can, recover some of these, it's always a great thing. And again, we abide by institutional guidelines, state guidelines, and absolutely, we want to make sure we honor the family's wishes. So that's always one of the most important things. Next slide. All right, so I'll just give you a brief process from like a perfusion standpoint. All the selection criteria is outside my realm, but from kind of like what we view, there's always communication amongst all the team members. The hospital, the OPO, the people setting up the organ procurements. Ourselves, our team, abdominal team, making sure that everybody's on the same page. So, there's no confusion. And then a final timeout is performed prior to withdrawal. Typically takes place in the OR or the PACU. Again, that's depends on the institution. We get a baseline loaded blood gas, so we can kind of see what the hematocrit is. Again, we for us, we try to make sure it's over the 25% mark. And again, if needed, they'll hang a unit and transfuse up to that 25 mark. And then, again, depending on the guidelines where we go, it varies on how much we can get done prior to. So sometimes they're able to prep and drape, sometimes they're not. Sometimes we can set up our circuit and have it ready to go. Other places we can't. So, that affects that ischemic time for us. Shaves a couple minutes or adds a couple minutes. It just depends. Next slide. All right. So, typically the family comes in during the withdrawal stage, and all the procurement teams that are gonna. I feel like guests to the hospital. We exit and are away. So that there's no mixing between, and they do the withdrawal, and that's kind of start that ischemic time Matt talked about with the OCS. We kind of kept those same parameters that systolic pressure of 50 or the SAT of 70%, whichever comes first. We start our timer, and again, like I talked about in the last slide, it just depends on what we can have done prior to. So there's a standoff time we have to consider, how much prep and drape we have to do, and the incision and sternotomy. We have to take into account those crucial minutes. Next slide. And so after the patient progresses and everything is declared, the family is taken out, and then the procurement team enters. We await that final confirmation, and then incision sternotomy is performed. And with this, the head vessels are clamped immediately, and then attention is paid to central cannulation. Next slide. And so from our standpoint with perfusion, these are just, the main things that we bring along with us. We use a centrifugal pump, and then our custom ECMO packs, and we turn that into a closed loop system. We incorporate a reservoir with the oxygenator, and essentially, we go on bypass when we're ready. The few other things, drop suckers we use, and then obviously we use vacuum assisted drainage. Next slide. And these medications that we use, majority of them are from the OCS. We incorporated a few more, such as the acetylcysteine, and I think some rocuronium. For obvious reasons, we just want to make sure everything goes smoothly. And yeah, I think that's pretty much it. Like I said, from a perfusion standpoint, it's essentially just like a crash on bypass situation, making sure that we get on safely, and the main goal is to reanimate within the body instead of explanting and putting it on the machine. We're doing everything in situ, and then watching it for about an hour. We pump the heart, and this allows systemic perfusion for all the other organs while they're making their preparations. And then after everybody's ready, we just do a traditional cross clamp, and everybody flushes as usual. And from there, it's just like a traditional procurement. Next slide. That's it.
I think that was the last slide.
Cool.
Yep.
Okay.
Dude, this is fascinating stuff to me.
It really is.
I got to tell you, I've seen a lot of things in my years, and Joey, I got to ask a question to you though, just very quickly. On that second to last slide, so you go on bypass it with a traditional oxygenator and reservoir. So it's not like you don't crash on ECMO. You're actually using a regular oxygenator with reservoir to completely decompress things. Is that what you're doing?
Correct.
But you bring a but you're not bringing a whole heart lung machine with you. You're just bringing an ECMO circuit.
Correct.
And so
So, I mean, essentially, ECMO with a reservoir, however you want to label it. Yeah, I mean, it's bypass for all intents and purposes.
Yes.
And I think that reservoir is the most important part, only because I don't know how much experience anyone else has, but when we first open the chest, the heart is hugely distended because all the venous return just kind of pools in the heart. And going on ECMO wouldn't be a great way to start. We want adequate decompression, so that's the purpose of the reservoir. And then we also occasionally we'll add in a PA vent to even decompress further.
Okay, yeah, that makes sense. So, I mean, especially if you're, like, what percentage of the time are you doing, like, can you use this device with the heart, lung, and block, or is that not feasible with the DCD device? That it has to either be heart independently, lung independently, liver independently?
We perfuse the entire body. So the first thing we do when we open the chest is we clamp the head vessels, and then we just cannulate, right atrium and aorta, just like a standard bypass case, and we perfuse the entire body. Now the Transmedics device, you have to divide, you take the organs out individually and you put them on the device on the back table. You can do liver, kidneys, pancreas, lungs, and heart, but they all have to be done separately, and there's no reperfusion inside too. So it's all done on the back table. And so there's a period of warm and cold ischemic time prior to starting the actual reperfusion of the organ on the Transmedics device. There is a group in Europe, though, that has been able to modify the Transmedics device to do a heart-lung block on the Transmedics system. So they've basically taken the heart Transmedics device and added a ventilator to it. But outside of that, most of the organs on the Transmedics device are isolated.
Yeah. May I ask one last question, and I promise you can ask all yours? I'm sorry. When you guys clamp the head vessels, notwithstanding this patient has likely had a neurologic event of some sort, do you see a lot of neurohormonal outflow of pressure anything that affects pressure or heart rate or anything else?
Not typically, no. Once the head vessels are clamped, and we clamp all three, we clamp the innominate, the left common carotid, and the left subclavian prior to initiating full support. We don't see some of the changes you would expect for someone who's brain dead. Those come usually after some period of time, but not in the acute setting. There are some, the ethical concern is that there are some collateral routes to perfusion of the brain. Although the thought is that with clamping the brachiocephalic vessels like we do, you've eliminated probably most of the flow, and that's how you justify ethically this technique.
And then additionally, in the list of drugs, a lot of the hormones we use levothyroxine. A lot of the hormonal, your native hormones that you actually get from in the brain or from cerebral perfusion, because they are clamped, we're substituting and we're delivering those hormones in our prime to account for that the loss of that.
Tammy, go ahead. I know you have a lot of questions.
Well, you actually asked a couple of them. I do have a couple questions, and mine are more mostly technical, just for the perfusion part. So I wanted to ask, I saw del nido cardioplegia. What are you doing with that? Are you using cardioplegia?
Yeah, so traditionally speaking, when they go for a heart procurement, when everybody's ready, they cross clamp and flush. I can't speak from like a traditional standpoint of what they use, but for us, they use del nido. So yeah, I mean, we just when they're ready, we cross clamp, and then they use cardioplegia. We just use del nido, and that is like we would in the OR just to arrest the heart, and then it's procured, taken on the back table, prepped, and submerged in ice and transported transported the traditional way.
Okay.
With the OCS, we use the same thing when we're ready to cross clamp, flush, arrest the heart, and then we take it to the box and reanimate it there.
I see.
The difference in those two techniques is that with the Transmedics device, we open the chest, drain about 1,000 to 1,500 mLs of blood into the device or into a bag, which is then added to the prime, and then we klege the heart with Del Nido, although the heart is not beating anyway. We just do it as kind of a protective.
It's a protective
and
measure.
then we cut it out and take it to the back table.
I see.
In the Nrp technique, we crash on, after clamping the head vessels, we crash on, reperfuse the entire body, including the heart, and usually you see reanimation of the heart, and the heart, 9 times out of 10, will go back into sinus rhythm. Occasionally, you do have to defibrillate or cardiovert, and then we'll reperfuse like that for about an hour. And then once everyone's ready, we'll cross clamp, give klege, cut the heart out. So just the timing of when the Del Nido is given is the big difference between those two techniques.
Okay.
And it's a little bit ironic that you've got the abdominal team. It's taking roughly about another hour that they're usually not used to having to be at the procurement facility, but the positive feedback we've gotten from some of the liver surgeons is that because we've reanimated these in situ for an hour and more or less turn the organ more or less back around from being in a very ischemic state, when they go to reimplant, we've gotten a couple of phone calls back saying that the liver started making bile intraoperatively on the more or less transplanted organ. They're coming back a lot quicker than what they normally see on a traditional organ transplant. We've gotten a couple phone calls from those the liver sites.
Yeah,
and to speak to that, the liver surgeons will often say, well, this organ is going to act like a DCD organ, which means the LFTs are going to, the liver function test, AST, ALT, are going to shoot through the roof initially and be slow to come down. Whereas the ones that are perfused systemically with our Nrp technique, I've heard stories of post-liver transplant patients with ASTs and ALTs that only peak in the maybe 200s, which is exceedingly low. And so we've also explored routes of doing this even when we're not taking heart and lungs, just doing this for the abdominal teams to allow their liver and kidneys to reperfuse more quickly.
Yeah, that was actually my next question was, are you working together with these other procurement teams, even if you're not doing heart or lung procurement? Because it seems like it would be better for the organ for them as well.
Yeah.
So okay.
Yeah, we haven't established a mature program for abdominal procurement yet, but we have done a few runs where there were some, early in our experience, we had some injuries to the aorta, which put us in a situation where the heart was non-salvageable, but we still were able to systemically perfuse the body for 45 minutes for the abdominal team to do their dissection, and those livers and kidneys did well.
And to that point, I would say we've done 19, 21 of these as far as the Nrp, and probably we've done probably the last 3 or 4 probably the same way. But this is a constant evolving technique that it's you see something or hey, what would we do better, or we run into an issue and go, okay, well, we had that issue, we didn't see that coming, or that didn't happen yet, and then we just overcome that. To Dr. Hoffman's point, we've changed aortic cannulas from one to another, and then we've done one more modification where we use a stylet, a sterile stylet, because when the patient has been declared dead, they have a very flaccid aorta. So I've never cannulated someone, but I have seen the struggles with people cannulating, and it doesn't seem like it's a very easy technique.
Yeah. Huh. You talked a little bit about the lactate levels. What kind of lactate levels are you seeing, and what would be the ranges that you would decide that the lactate is too high and this is not going to be a good donor?
So I was going to say, typically for OCS, non-DCD OCS, they usually start low and climb, and then we're making adjustments to try to plateau and decrease it. With the OCS DCD trials, they typically start high and drastically reduce. And then with our NRP, they kind of mimic that, where they start high, and then as we perfuse, even just for that hour, that systemic perfusion, those lactates tend to trend downwards pretty quick.
I see. And how?
And the one additional I'll add to that is that on the OCS, when we're using the OCS heart device, the lactates are reflective solely of perfusion of the heart and the lactate that's being generated there. And so, in my experience, and correct me if I'm wrong, the lactates are usually below 5.
Okay.
When we're doing the Nrp technique, the lactates we check are reflective of entire body malperfusion, and our first lactate is typically close to 10, and typically will come down to 9 or 8 after about an hour of perfusion, and that's not so much to evaluate the organ,
Okay.
because again, it's still in situ. It's to evaluate the adequacy of our perfusion to the entire body.
Oh, I see. Okay, that makes sense. How often do you go and determine that that the organ is not acceptable? Is that something that's rare, or do you find that you travel somewhere and then after you do this perfusion that it's not going to be a good organ?
Yeah, there are a couple of reasons we could decline an organ. I mean, we can decline it before we even go out there for one reason or another. Either it's coronary disease or the function doesn't look great. When we get out to the center, we could decline it if something's changed in flight, which doesn't happen often.
Okay.
We could decline it if, for instance, we extubate the patient and they don't progress to agonal in a period of time, or if we extubate, they progress to agonal but don't progress to asystole within a period of 30 or 35 minutes, depending on which technique we use. And then once we've decided we're going to take the heart, if we put it on the box and the lactates don't fall or they're above an absolute number, then we can decline the organ. If we're using the Nrp technique and the heart just doesn't look good, for instance, maybe the RV dilates when we come off pump, or there's some other issue, then we would decline the organ at that point. So there are a lot of different times where the organ can be declined for one reason or another.
And I will say, I think we've declined out of the OCS that we've done, and I'm not going to stratify whether it was DCD or a regular, but I think we've only declined 4 hearts, and we've done, I think, well over 20 or 25 of the OCS. And the NRP is actually, those organs are actually, they seem to be a lot better. And I don't know if that's because the criteria that that we select, most of those patients are very young patients. I think we've done 13 years old all the way up to about 42 on those, but they just seem, those organs seem to to be pristine when they come off. When we bring them back, the transplanting surgeon gets the heart out of the cooler, and they're just very impressed on how that organ looks. Even they made the comment that it looks better than usual.
Oh, wow.
And Dr. Hoffman.
Yeah, I think that just goes to the selection criteria. I agree. We've done young donors, and actually our cutoff is 35 years old, because this is the start of this technique, and so we're just being very conservative with our selection. So the donors are admittedly very ideal compared to normal brain death donation.
But once again, those organs would not be used. I mean, that heart would not be used on a 35, 13-year-old, 18-year-old. Those organs are not on the market. Not to use a bad term, but they're just not going to be utilized. So we are actually pulling organs from donors that would never be considered donors.
Right. Otherwise, they would have just been wasted, if you will. I get that. Okay, I think that's all my questions. Joe, you have any follow-ups?
Yeah, I did. So a couple of curious questions is when you put someone on pump, and I'll ask Joey if I can ask you this, and then maybe you can include the other guys with you. But do you see any value if you have a patient who may be have very high lactate and you're trying to get that under control early when you go on pump with your miniature circuit reservoir decompress and you're flowing? If you, let's say, had some renal dysfunction or other dysfunction that maybe you couldn't get that lactate cleared, is there any value in using some type of continuous renal replacement therapy simultaneously to clear all of those metabolites, essentially, and some of the inflammatory mediators while you're in that reperfusion stage, reanimating the entire body?
Oh, I'm sure there's some great value in that. The issue that comes to my mind is time. I mean, we're only on pump here for about 40 minutes to an hour. I don't know how we would be able to effectively set that up or bring it with us. Have all that extra equipment, to be able to do that. Really what we're focusing on is adequate systemic perfusion. We haven't quite run into those issues yet, but again, I don't know how we would be able to incorporate extra equipment.
Well, we bring a hemoconcentrator to where we could potentially Z-buff, and we bring all of that. The problem that we run into is we thought early on, we're like, oh, that'd be a great idea. We'll be able to hemoconcentrate. It may have a lot of volume on board. Whether it's a trauma patient, whatever it is. Crits are low mainly because the patient, probably, bled, and they did probably give some units of blood, but they also gave a lot of crystalloid, right? So the whole idea is we thought, well, we'll go ahead and when we go on open reservoir, we'll have a lot of volume. What we found out is that when we go on, we do have a good amount of volume. And in the beginning, we did hemoconcentrate to try to get higher crit, more boxcars running around a little better. What we didn't realize is that we're fully heparinized, and there are multiple different organ procurement teams working, and in the typical organ procurement fashion, they don't really. Bleeding does not really cross the other team's minds, and so because they don't have a reservoir, on typical procurement, the heart is beating. You got an anesthesiologist taking care of the pressures and the volumes up there, whereas we don't have any. You know as well as I do, Joe, that when you're low on fluid back there in the reservoir, you have a couple options. You drop crystalloid or you drop blood. We end up using between 2 and 4 units of blood after we go on pump, because of the blood loss that we get with the abdominal team.
And these guys are being nice. I mean, when we open the chest and shove a cannula in the right atrium, it's not the most hemostatic thing, and sometimes we get blood on the floor. But again, we have 4 units available with each case. And I think I've only been in one case where we didn't have to give additional units. It was that last one we did.
Hey, and we're getting better at it. But the whole bleeding issue, we're fully heparinized, and you're dealing with multiple different organ teams that aren't used to having people on bypass. I mean, a pancreas team or a liver team or a kidney team, they're not used to having fully heparinized patients that require us to have blood back in our reservoir, and so it's a very well respected discussion that we try to have, not only in the timeout but even intraoperatively, and when they're compressing, when they bring out when they're bringing the intestines out to try to try to dissect down on their specific where they're wanting to cannulate and things. A lot of times they're compressing on the IVC, and all of a sudden, like, hey, anybody pressing up there because I got no volume.
Hey, Matt. Hey,
Yeah.
Matt. I'm sorry to interrupt you. Hey, Dr. Hoffman, could that thing you've got in your hand that you keep spinning, it creates a bunch of buzzing.
Go ahead, take it
So
away.
I know you. Yeah, so
Yeah, he just doesn't get to touch it.
so you're not allowed to touch that.
He's a
That's
fidget spinner.
That's a perfusion device. You got to stay.
I'm done.
Can't touch that. Fair enough. So
you're saying if you take off the volume, you end up adding the volume anyway because you're having a lot of bleeding, possibly in other areas of the body.
Mhm.
I see.
Yeah.
Yeah.
And not only do we, would you add the volume back, even by not taking volume off, we end up giving more volume.
Yeah.
So, the volume, that is really our biggest struggle because we'll get to 45 or 50 minutes and it's almost to the point where, and you don't want to give a lot of pressors because that's that's contraindicating what you're trying to do is, get good regional perfusion.
Yeah.
And so you're trying not to give pressors, but on the same token, you have to have something in the tank. You don't want to drop crystalloid at the very last minute because that's going to disrupt. You're trying to get your organ completely buffered perfect right before it goes into cold transport. So there's a lot of things that we're trying to juggle a lot of balls at the end to try to maximize the more or less the cold storage. And it's literally a finish line a lot of times where we go, hey, we have to come off here.
I see.
well, I think
So that's
I think for me that all makes a lot of really good sense. I have a question for all of you, and you can each answer this question. Actually, a couple of very quick questions. Quick questions, but complex answers. This is a very new device. It's very limited in who is using it. This technique is certainly, I think, revolutionary in regards to how you're treating these patients to expand your organ pool. So, one is, how much are you really expanding that organ pool? And given what seems to be, and correct me if I'm wrong, the somewhat labor-intensiveness nature of these techniques that you're doing, where do you see it going in the future? Is this going to get simpler, more automated? You're going to start expanding it out to even using it on even farther away patients. So what are you accomplishing? Number one, how many people are doing this? What's the goal, and where do you see it going in the future? And you can each answer those questions in whichever order you prefer.
I'm going to defer to Dr. Hoffman.
Well, I can start really quickly. As far as the Nrp technique, in the United States, we are the only group doing that.
Wow.
There's a group in New York who is bringing the donors to their hospital and then cannulating them, basically using Nrp, but the donor has to be moved to their hospital, which is a major drawback to that method. We're the only team or group going out to the donor and getting a heart using Nrp. So we've traveled 200, 300, 400, 500 miles just to get these hearts. And we've extended our total ischemic times almost up to 4 hours at this point. There's a group in Europe, the Papworth group, who and they're doing Nrp, but they're not using cold storage like we are after we cut the heart out. What they're doing is they're using Nrp and then taking the heart out and putting it on the ex vivo Transmedics device. And so their technique is also a little bit different. So we actually have some research and a paper coming out that's going to demonstrate the effectiveness of this Nrp technique with cold static storage up to 3 or 4 hours, and which in my mind is revolutionary. Where I see this going, I don't think this is a technique for every center. I think, like you said, it requires 2 perfusionists, 2 surgeons, and a preservationist, and it requires a lot of resource mobilization. So I think you're going to see this done at big centers, but smaller centers are not going to pick this up. For us, we did 8 in 2020, and we've done another 8 in 2021. And just doing 8 with a total transplant volume of about 128 adults, that expanded our transplant volume by 7%. And so I think we'll settle out somewhere between 7 and 15% increase in our transplant volume just because of the Nrp method. The Transmedics has also expanded our transplant volume to the same amount. I mean, we've done almost essentially the same number of DCD NRPs and DCD Transmedics OCS. So probably 15 to 20% when all is said and done, we've picked up 15 to 20% increased volume in DCD donation at our center. So again, you won't see smaller centers doing this; you'll see bigger centers doing it.
Mm-hmm. Mm-hmm. Yeah, that's going to be very interesting because, you know, of course, you really have to. It sounds like a technique you have to be good at. You can't just do it once in a while. It sounds like something you have to be seriously dedicated to and have the number of patients that you need to have that routine down so that you know what's going to work and so forth. I can understand easily that trying to expand this into smaller centers could be disastrous if that happens, because it would take those patients potentially away from somebody with more experience and the outcome might not be as good. So I always worry about that and how industry is going to try and promote this and push it out into anybody can do this, everyone should be able to do this, and dilute out the actual benefit of it. I don't know, that's my thought. I don't know if that's something you're concerned about.
Yeah, I think that I think the other thing is that smaller centers may have a shorter transplant or wait list and don't necessarily need a technique like this because they're able to reduce their transplant list with just standard brain dead donors. For a program as large as ours, we have many people who might otherwise be waiting on the transplant list for a long period of time. And we found that consenting patients who are interested in receiving DCD donated hearts actually shorten their wait list time significantly. You know, at least if they consent to the use of an NRP heart, I've found that they shorten their wait list time by half. And that's just the NRP hearts. I don't know if that changes anything for the Transmedics device, but you can shorten, you know, there are different techniques to shorten your wait list time. So this is just one of them.
Mm-hmm. Did you have something?
I have one follow-up question. So I know you have a large team of perfusionists there. Is everyone on the rotation to do these sorts of things, or you have a specialized group? How do you handle that?
I see Matt smiling.
That is becoming more of an issue for us because I mean we in the month of March we did 10 hearts in the first 9 days of March.
Wow.
And so when you're going out and these they're none of these things that we talked about today, whether it be OCS or NRP, the fastest from when you leave Vanderbilt to come back to Vanderbilt with the organ, it's never less than 7 hours, and that's 2 people out for a significant portion of the day, which and then you know when you're transplanting the heart, you actually have a third person on this particular case. You've got 2 doing the procurement. You've got 1 that is taking care of the patient, the recipient back. So you're talking about 3 perfusionists that are you know a significant amount of time, whether it's 5 to 6 hours on the transplant patient. We do not have a lot of people that are interested in flying and going to do this. About half our group does it, and the other half backfill the holes that are left with the people that do go.
Right. Well, that's what I was curious is how much, because I knew that, you know, especially traveling further and further, that's just going to lengthen the entire experience of going to get these organs. And so I was just curious, you know, how you were managing that. I'm sure, you know, this is an exciting program for you, but again, it gets back to staffing and man hours and all the things that surround that. And I know that's going to be very challenging, but it sounds wonderful. I
It
think it
does.
sounds really exciting.
Well, I told Joey, and I did a horrible job, by the way, introducing all of you all, but we were apparently there was some mishaps, and when you throw me off, I'm a perfusionist, right, like all the rest of us here, except Dr. Hoffman. He just tries to be one, I know, but and some he likes to touch things. That's what we do, Doc. So you're good.
I've got a bypass machine in my office.
He
I
does.
don't, no doubt. We'll accept you into our fold. But when you throw me off, you get the system thrown off. It goes terrible. But Joey, you're a graduate of the Vanderbilt program, right? And I think
That's
you've
correct.
now been working there for 4 years. And when we first met, I told you that your 4 years there have probably worth more experience-wise than 25 years
Yeah.
having worked someplace else. So you've got a phenomenal career ahead of you for sure. But I understand this is you 2 heart surgeons, you have 2 perfusionists that go on these things, you have someone that you said maintains the physiology, or somebody else.
Back taking care of the recipient, right?
No, there's
Oh.
somebody else on their team. So you have
Oh, preservationist.
preservationists, right? Preservationists.
Okay.
The labor intensiveness of it, the time it takes you to do this, basically the interruption of whatever personal life you thought you were ever going to have. How did you get to where you are? Why do you love doing this so much? And what do you think about all of it in terms of the amount of work it takes to actually preserve this organ, specifically in the Transmedics box is what I'm talking about, the heart in a box technique. What are your thoughts?
I don't know. I mean, it's from a personal standpoint, I've always kind of been a worker bee. And the technology involved is fascinating, and then, most importantly is we're giving these patients, kind of a second chance. And, I think that's what we really, lean on is these people, they need some help, and, that's what we're all in healthcare for. And so, if I have the opportunity to jump on something new, I go head first. So, it's been exciting. I'm lucky to be involved here at Vanderbilt, and so I just, take every opportunity I can.
Did you?
And Joe,
Go ahead.
sorry, Joe.
No, you go ahead, Matt.
And we all think about the recipient, right? Typical perfusionists don't get to see the donor family.
Mm-hmm.
They don't get to see that, and so we do try to keep we're not in there when the patient expires, of course, but without a doubt, you get glimpses, or you get the story from the staff there, but there's also something to be said about the family of the donor, right? They have some terrible misfortune, tragic story has happened to that family, and the only silver lining on the table that's left for them is that they know that by giving the gift of organ donation, that's the silver lining in it for them, in their darkest hour.
Yeah.
And so I have seen that where people are like, yep, but and they say he or she was a wonderful person, and they talk about that they were very generous person in life, and with the donation, it just kind of epitomizes who they were while they were living. And so I think we, as a perfusionist, until I went on these, I didn't really fully realize the impact of actually the donation that can be probably the only uplifting nugget in the story for the donation family.
Mm-hmm.
Mm-hmm. That's a very good point. I was actually thinking of that because, it's often can be seen as a way to honor the donor's, philosophy or their life that how they lived, what they would have wanted done for them. And, you know, families are trying to take great care into doing those things, especially, you know, at the end of someone's life. So I think that's a really valid point, and I'm glad you brought it up. Joe, you had something?
No, I think that was about it. I do have. Do you guys have any final thoughts, Dr. Hoffman?
Yeah, I want to just recap for everyone watching. You know, the DCD is an up and coming method of procurement for hearts. We're still in the infancy. I know that these were, you know, the early heart transplants that were done like this, but this is a technique that's kind of made a resurgence. So just to recap, there are 4 typical ways to go about doing this. There's the DCD Nrp process with cold storage, which we do. There's the Transmedics device, which is you pull it out, you put it on the device, and you bring it back. There's the hybrid approach, which is the DCD with Nrp, cut it out, and then put it on the OCS device for travel. That's the 3rd way. And then the 4th way, which we haven't talked about at all yet, is what I call the grab-and-go technique, which was basically pioneered by the University of Colorado group in 2008. But no one really does that. I think one day we will get there. We're just not there yet. But my prediction is that we will get there one day, and it'll basically go back to being a surgeon and a preservationist, going out, getting the heart, taking it out of the body, and coming back on ice. But for right now, I think this NRP technique works, and it's you know, all our patients have done very well with it. So.
Well, you have a lot to be proud of, you know, especially being, again, I don't want to be redundant, but I want to stress, because I think it's something to be very proud of, being recognized now as #1 in heart transplants in the world. I think that's an incredible, it's an incredible accomplishment, and something you should be. Oh,
your mic's.
Oh.
You're not wearing it.
No, I'm getting as bad as Dr. Hoffman. There you go. Something you should be very.
But you run a program.
I run a I know. Well, they should have noticed it over there. They didn't notice it, you know. So you see how much help I get around here, Matt? I get treated horribly. Joey, you need to come here, you know. So anyway, but I had really blown. I think it's something to be really proud of. But I blew it when we first started because there was all that discombobulation. So for everyone in the audience that's watching, and also for you guys, this is how we were actually supposed to start the program. So if you could just indulge me for 1 second, we created a little introduction. We can play it, come back on, we can close up, and we can all get out of here exactly on time, if that's okay with you, if you don't mind. Go for it, David. So that's what we were supposed to do, run your introduction. So there it is, a post-production, whatever you want to call it. Sounds like a turducken. But this has been a fascinating conversation. I've really enjoyed it a lot. Matt, maybe we could get together and talk about, we'll get better at it, of course. Everything is always an evolution. We get better at everything that we do on a more routine basis. I understand that our program is going to be predictable as the first, I think we agreed on the first Wednesday of every month. We'll get the new topics that you guys are going to be doing, and it can be from the cardiovascular department, perfusion department, critical care department. The sky is the limit as far as what we're doing, but the whole concept, the whole idea is that we are sharing our knowledge from more than just one place, but multiple places around the country, because we all have experiences and things that we are really good at and can learn from each other. And I think that's ultimately the goal, is to make sure that the information that's getting out there is usable by our colleagues, understood by our colleagues, and people also learn and understand what resources there are out there for us to manage difficult patients, because there's a lot of people with a lot of experience. You just have to know where to go to get that information that you might need. And you guys clearly like to share your expertise and do things that are right for patients. So we appreciate that. With that said, I'm going to pass this over to Tammy, but ask you guys if there's any final thoughts that you have or would like to say anything else before we say goodbye. Until next time, please, the floor is yours.
I appreciate it, Joe. We'll see you next month.
We're looking forward to it. Joey, any thoughts on your first program?
It's been interesting, but you know, I do appreciate you having us on. Looking forward to some more.
Well, we appreciate it too. Dr. Hoffman?
Nothing more to add about the DCD stuff. I mean, I could talk for hours about it. I've got other things we can talk about, and I'm sure we have topics for the future.
Yeah.
Well, hopefully we can do that next program. Go to step 2 of this program so that we can continue to talk about exactly what it is your passions are. I'm willing to do that all day long. So we thank you for that. Tammy, if you'd like to close us out.
Yeah, thanks for joining us, guys. It's been a real pleasure. You guys should be really proud of you know, the accomplishments that you've done at Vanderbilt, and we're just so thrilled to have you be a part of this collaborative effort. Yeah.
I think that's perfect. Thank you, guys. We'll see you in a month. And Matt, I'll give you a call later on this afternoon. We need to come
Sounds
up
good,
there.
Joe.
We need to come up there and work on your cameraology a little bit.
All right. Thanks,
Bye.
Joe.
Bye.
Thank you.
Okay, David, next intro.
All right, and we're back.
And we're back. And I've been ordered to move over. Okay. Tammy, welcome.
I'm not going to be in my lap anymore.
Tammy Sparacino, Journal Club number
18.
18.
18. Who's counting? Welcome, everyone. I hope you joined us for our first segment of the Vanderbilt University Medical Center Forum.
Faculty Forum.
Faculty Forum. I got to get that down. We are here today to also do our monthly journal club, and today we are going to be, do I need to share my slides, David, or are you ready?
Yeah, do you want to do it from the iPad?
Yes.
Yeah, just mirror the screen.
Okay, hold on one second. Oh, that's not it. And screen mirroring. There we go. Okay, so today we are going to be discussing a commentary article that was published in January of this year in the Journal of Thoracic and Cardiovascular Surgery. And Joe actually picked this one. It kind of sounds like something he would say anyway. The title is Commentary, Fool Me Once, Shame on You. Fool Me Twice, Shame on Me, Preparing for Acute Aortic Emergencies and the Next Wave of the COVID-19 Pandemic. Co-authored by Dr. Lau and Dr. Galdino. All right, the central message is pandemics overload the healthcare system and hinder care of emergent medical conditions. Management algorithms promote safe and expedient care of patients with acute aortic emergencies during these times. Well, the reason why this paper was published, I'll go ahead and just tell you, it was to review this article, or give a commentary on it, really. And this article was in the same issue from the Journal of Thoracic and Cardiovascular Surgery. And the title is Triage and Management of Aortic Emergencies During the Corona Disease 2019 COVID-19 Pandemic, a consensus document supported by the American Association of Thoracic Surgery and the Asian Society for Cardiovascular and Thoracic Surgery, with the primary author, Dr. Mehta. It was published October 30th, 2020. Okay, the problem that to be solved in this particular article, it can be summarized here. The corona disease 2019 pandemic has placed an unprecedented strain on hospitals worldwide, necessitating healthcare systems to triage patient care and redirect resources, including personnel, equipment, and operating rooms. Aortic emergencies, including aortic dissection, rupture, malperfusion syndromes, are resource intensive and therefore can overwhelm a system already operating at maximal capacity. Although healthcare systems are necessarily shifting resources to address the COVID-19 pandemic, a contingency plan to continue to support aortic emergencies needs to remain in place. This document is meant to facilitate triage and management of these acute patients based on best available evidence. Okay, let's talk about their methods and procedures. So we'll go to their specific central message for the article. Is they created an algorithmic approach to acute aortic emergencies during the pandemic to reduce the risk of exposure for patients and healthcare providers. And something that's important to remember is they were creating this in the beginning portions of the pandemic. And so it's going to be interesting to discuss how these sorts of things have or have not been implemented in what we have now been doing for a year. Okay, so they did a graphical representation of, and they're specifically looking at aortic emergency diagnosis, but it could really apply to any type of cardiac surgery if you think about it. So they have three main categories. So a known COVID negative, a COVID unknown, and a COVID positive. And we can just follow through here. These patients are presenting in the ED, and they are determining for the COVID negative, symptoms of CT findings, are they concerning for infection? Mainly, are they looking at x-rays of the lungs, and are they seeing anything that could possibly be a COVID infection? If no, then you just go through your normal routine OR and routine surgical ICU. If there is something that's suspect, then you put them into the COVID unknown. And that would be using full COVID PPE, a rapid COVID-19 testing, and from there you're going to have specifically a COVID OR. You're going to do the all the types of things that you need to do after intubation, and then you're going to recover in a COVID ICU. And then if the test returns negative, then you just move them over to the routine surgical ICU. Now for the COVID positive patients, you're going to do, of course, all the full PPE precautions and consider early intubation to reduce the viral spread. You'll do your operations in the COVID OR, and then you will recover in a COVID ICU. Okay, so then they wanted to look at, well, what if you have one of, you have a referral, you have someone who has an aortic emergency that needs to come to a center that handles those sorts of surgeries. They thought it would be prudent to also have an easy flowchart type of procedure to be able to manage these patients. And it's all very similar as far as what you're doing at the referring facility. You're breaking them up into COVID negative, COVID unknown, and COVID positive. But what's going to happen when they get to their new hospital, they're going to be transported to designated preoperative staging area at the receiving hospital. And then the EMS is going to hand off to the OR staff there, confirm diagnosis on imaging for their aortic surgery, and then they will break them down into the same types of categories as far as COVID negative, COVID unknown, and COVID positive. Then they created, it's actually really lengthy, step by step, everything that you can consider. But I thought it would be interesting just to, and for time's sake, just to go over their summarized table. There's preoperative considerations, rather. You want to try to get your evaluation done before you transport to the OR. You want to make sure that you do have that staging area for direct to OR protocols so that you're not mixing these patients with other patients. You're going to have your appropriate PPE measures. They should be strictly followed for all personnel who are going to be interacting with these patients. Surgical procedures should ideally be performed in the COVID-19 designated ORs that have the capacity and capability of providing negative pressure airflow, which I wanted to just break away for a second and comment on that. Little did they know at the time that we would have so many that we wouldn't have enough negative pressure ORs. But they don't know that yet. You know, this is being formed in the beginning of the pandemic. The minimum number of personnel should be required to have direct contact in patient care. Again, they didn't know that we would have so many that it would end up having to be your entire staff for the most part. You'd have anesthetic considerations. You want to minimize all exposure to, you know, any aerosol generating procedures. Recommend endotracheal intubation to include rapid sequence intubation, making sure you have someone who's very experienced who can perform the procedure quickly. Elective use of video, and I have trouble with this word, Joe.
Which one?
Right here, video
laryngoscope.
Laryngoscope, thank you. And if testing for COVID-19 was not yet achieved, a sample should be collected once in the operating room. Ventilation.
Some people say laryngoscopy.
Okay.
But laryngoscope.
Okay, thank you. Care should be taken during the TEE examination, including PPE. This table continues for procedural considerations, prepping and draping in the normal fashion, making sure that you're doing quick repairs over complex repairs. Consider blood conservation management strategies, and chest tubes should be checked for air leaks and secure connections. Then the post-operative care is ideally in a COVID-19 designated ICU, which of course we saw that in the beginning, and then we ran out of ICU room. Extubation criteria should be carefully considered to mitigate the risk of reintubation. Okay, what were the conclusions of our commentary authors? Well, after looking over this article, they decided that with appropriate use of PPE and designated COVID-19 spaces, the risk of nosocomial transmission can be kept to a minimum. Undoubtedly, some healthcare workers have been inflicted with and succumbed to COVID-19 from work-related exposure. However, the transmission rates have been very low with adequate awareness and PPE in use. In a series from a large hospital in Wuhan, China, the infection rate was 0.5% among the first-line healthcare workers, and the rates were higher in early stages of the outbreak when PPE was less stringent. Proper algorithms can allow us to stay safe while providing expedient care to those with aortic emergencies.
Can you really believe that? I mean, in all seriousness.
No, I mean, we've seen much more, but they're just referencing that one study.
From a place that, are you sure we can believe that?
I don't know. All right, so do we want to have a little bit of panel discussion?
Yes, I'd love to have a panel discussion. Can
Okay.
you please go back to your slide, the one with the algorithm?
The initial one?
Yes.
Okay.
Can you throw that up?
Yeah, it's
Is
up.
that up? Okay.
It's up.
Yeah. Okay. So what I'm looking at here is if they're COVID negative, symptoms or CT findings concerning for infection, no. Routine OR, routine surgical ICU. Okay. That doesn't mean that they weren't infected. Number one, I don't believe. And number two, you know, just because they test, there was false negatives, there was a bunch of false negatives, right? And there were also a bunch of false positives, okay? And what I see from this is essentially a delay in care. What I gathered from this and from everything else is we went through this big long process, and these are aortic emergencies, right? How many of these patients that were probably already aortic emergencies not being treated the way they should have been treated, and they evolved or devolved from aortic emergency to aortic disaster. So, with that said, I look at this flow chart and I just think to myself, you were 100% right. You pointed it out. We were overwhelmed with patients. Patients were afraid to come to the hospital.
And I'll get to that a little bit later in our.
Because you opened it up for discussion, so I thought we were ready to do it. So.
No, I'm going to talk. Please continue. I'm just letting you know I am going to talk about that a little bit more about patients of being afraid to come to the hospital.
And then, and not only that, but then afraid to be people at the hospital afraid of them.
Yes.
Because we don't know what's wrong with this person. We still have to treat them.
Yes.
But there's, all of the things that we did, everything we did was delaying what was the appropriate care that the patient needed at the time. And whenever you wait, it never gets better on its own.
Well, and I will agree with that. However, I do think that what these authors in this article that the commentary is about were trying to do was prevent that. They're actually trying to put a framework together so that a hospital can already have these sorts of things set up so they know where to track people for the fastest way to get them to care. Because, especially on, let me go to this next slide, coming from a different hospital, that's always complicated anyway when you have an emergent patient. So I took it as they have a framework already set up so that they know, okay, we're going to have this area where we receive these patients, and it's either A, B, or C, and you just, direct them as you could.
No known COVID, unknown COVID,
and then COVID.
Definitely COVID.
Yep, and you have a plan for
or
all
suspect.
Right. Well, no, actually positive. So unknown could be suspect, and COVID negative or suspect.
Right. So
positive.
COVID negative, COVID unknown, and then COVID positive. So is the unknown has to be is it suspect? Or?
Yes, they even say the negative is suspect because you're going to also do make sure if there's any symptoms when you do these CT findings for concerning infections. Like I didn't include this graphic, but they had a picture of a bilateral ground glass opacities and what did they call it? Crazy paving in a patient infected with COVID-19. So they were kind of showing you, what this might look like. Even though you weren't looking for that, you're looking for this, aortic emergency. But this patient is supposed to be negative, but then you see something suspect in your clinical findings, then you need to treat them as COVID unknown. In other words, likely infected, but we will assume infected.
Or previously infected with,
is
it active infection? Is that a sign of active infection? Or is that post-infection, granulation or whatever it is? Okay, well, thank you. I'm sorry. I didn't mean to interrupt you, but I was struck by this particular slide.
Oh, yeah. No, I mean, John, what do you think? I kind of thought that it was just trying to actually speed up care when the primary concern on everyone's mind, whether it be patients, OR staff, ED staff, EMS, is everyone's worried about getting infected just while doing their job or receiving care as a patient.
Absolutely.
Yeah.
John?
Yeah, you guys, good morning. Can you hear me okay?
Yeah, good morning.
Yeah, good morning, guys. So, if we just go back about, 9-10 months ago when this was all maybe just 2 or 3 months new to us, every patient that was sent to us, it took 3 to 5 days before we knew the result coming in from an outside hospital, right? You didn't get the result very quickly. So everybody was assumed positive until confirmed negative, right? So we treated people in the unknown category an awful lot. And then flash forward 4 or 5 months in the future, past that, we found out that the tests themselves was about a 50-50 coin toss on accuracy.
Right.
Right? Maybe 40-60 on a good day. It was 60% accurate. And then as time evolved and the tests got better and faster and a little bit more accurate, not terribly so, we now kind of feel like we're in a little bit more of a routine. If they're negative, we kind of feel like they probably are negative. If they're positive, they're positive. Usually they get more than one test, several days apart, to keep confirming that. But quite honestly, I don't know how it was where you guys were, but it was mayhem. I mean, it was, everybody coming in from an outside hospital was just an extreme, unknown. Everything, no stone was unturned to barricade the doors, and everybody had PPE from head to toe and wall to wall, and we had a separate entrance to our OR. You couldn't come in through the main front desk of the OR. I don't know if you guys had this. We actually have a side entrance, and all COVID patients had to come through their side entrance and leave through the side entrance. And we had one designated room for COVID patients that had to be completely, sanitized in a way that took somewhere in the neighborhood of 1 to 2 hours before anybody could go in there and do anything after that. So there was no back-to-back patients, and there was no buddy that could go in there. All the equipment that was unnecessary had to be moved out. If you didn't need a cabinet or didn't need a heater, cooler, or whatever it was, everything had to be pulled out into the hallway. So we're still doing some of that. We're still doing a lot of that. But at least now we feel like when the tests are done, we have a reasonable certainty that we actually have something of an accurate assessment on the patient's condition. But it's kind of a miracle to me to look back and realize that how little hospital infections in the OR personnel we actually had, because we were in such a unknown state of whether this patient has COVID or not. But I guess we were so cautious with the PPE that it saved the day.
Yeah, well, and I remember when one test wasn't enough, 2 tests wasn't enough. We were sending tests on patients that perhaps we wanted to transfer. Maybe they were, needing to go down to the medical center to have, some other kind of procedure done. 4, 5, 6 negatives before they would accept them and believe the test. And these are the tests that we're taking. We weren't even necessarily doing them in the hospital where the patient's located. So you're taking those samples, sending them out to have them run, and then it just depends on when they arrive, how long the list is of, tests in front of them. Sometimes you're waiting 8 hours for a test, and they're not running them overnight at this point. It was kind of a 7 to 5 or something kind of hours for the lab. So I know in particular, one patient of ours comes to mind that needed to be transferred, needed a heart transplant, and was on ECMO, and it took 6 tests before they finally said, okay, I guess he's negative, we'll go ahead and accept him, for these cardiac reasons. And then
I remember that.
Yeah, remember that? And then that also brings to mind, remember how we were grouping? We had certain hospitals that they decided this location will be our COVID location. And so then all patients are being transferred back and forth. Let's send them all to the COVID place because we want to keep them all together. But then that went out the window because we had too many. And so then we're making new floors for ICUs. And then we're putting up, temporary barriers, kind of plastic zip-through things we had to walk through. And in the very beginning, when we had our very first COVID ECMO, if you remember, we were doing actually what they recommend as far as limiting personnel. We only had a certain amount of staff that were caring for that patient. It was a couple nurses and then a couple perfusionists because we were really trying to say, okay, these are going to be our COVID teams, but little did we know that it was going to have to be everyone. Everyone's going to have to. Everyone's going to have to take a turn.
I have to ask John if he experienced this at all at any of the places where you go, not necessarily your current home, but I was assisting in a COVID unit in a big, huge medical center hospital, and we had 16 patients on ECMO in that unit at the time, and one of the patients had, their pupils were one pupil was blown, and it was there was obviously something going on. Something was wrong neurologically, likely a cerebral hemorrhage, and they wanted to do a CT of the head. So we and this is a place that would, when the patient was done, either weaned and discharged or passed, everything was taken to a special room where it was ultravioleted, with light, light on it. But we took that patient out of the unit, down a long hallway around 2 or 3 corners. We got to an elevator, took an elevator to a different floor, got out, had to go down a bunch of other long corridors into yet another elevator, passing by all of the different patient units, all of the different public areas, to another elevator and to the CT scanner, did the CT, and then turned around and came all the way back that same way. But when we got when we got the patient packed up to leave and got to the door, we all had to take our PPE off, all the stuff from in there, and then we had to go all the way through the hospital, and when we got back, put all of that PPE back on just to put that patient back in that room. And I'm like, what are we doing, and why? Why are we doing this?
Exactly. I mean, I remember seeing that, and it
was a 20-minute journey.
And for a while at one of our facilities, you had a security escort. So you're all PPE'd in the room. Then you're coming out. You take off all your PPE. I mean, except for your mask and your gloves, but you don't have all the other stuff on.
Yeah. You don't have the terrarium on your head.
the sweat factory.
The papper. Yeah.
Oh God. And then you're going through the hospital, and you're right. You all get in the elevator. Patient's there. Nobody's coming behind you spraying anything or cleaning anything. And this is back when you had a runner. So once you were like in an OR, you didn't even leave the OR. You had someone standing outside waiting to go get you stuff if you needed. But that goes all out the window when you have to take the patient somewhere. I mean, I don't know how we could have done it different, but it is interesting to think about now.
I think the only thing, I don't really think what we did, and sometimes I think that the way I talk about this may come across like I think that we did, or they did, or whoever did something wrong, okay? Really, the way I view the whole thing isn't that any of us did anything wrong. We did the best we could under extraordinarily unknown circumstances.
Agree.
The point that I try to make is that we're woefully ill-prepared, and we were ill-prepared for this, and it's going to happen again.
Yeah.
Are we going to be prepared next time?
Well, that's what I think. We didn't give John a chance to answer, so let's do that, and then I'll make my next point. Did you experience any of that kind of stuff, a breakdown in the kind of the system we were trying to control, the possible spread, and then yet other times we sort of went out the window?
Literally.
Well, yeah, let me back up to the first conversation with when you're talking about testing, but I want to talk about the transporting you just talked about, because we have the identical situation, absolutely identical every day still. But as far as the testing goes, not only would we get a patient who perhaps was tested negative somewhere else, so we were accepting them, but we don't trust their test. We have to test them ourselves. You didn't trust the other hospital's test to be negative. We have to test them ourselves at our hospital, even though the test was exactly the same manufacturer that they used, that we used. But nobody trusted anybody else's test. Right? We got to test them ourselves. Now that he tested negative at our hospital, okay, now we feel better.
Right. We did it right. We have the better test.
Yes.
Yeah.
Well, I mean, but that's true, because the swab has to be put in properly. It has to get. I mean, apparently, I mean, there's a lot of, every test has risk of technique error
and actually,
associated with it.
in this paper, they address that a little bit. I mean, it's detailed. It's not just Roman numerals and letters, and then it goes to type.
Ramen noodles.
Ramen noodles. It also goes to the smaller little, I don't know what you call those when your outline goes.
Finer points.
Yeah, but the little eyes and then the multiple little eyes and anyway, the finer points. That sounds better. They talk about this. They say that the nasopharyngeal swab may be attained. However, since there's concerns have been expressed over the sensitivity of this sample, when a patient is intubated in the OR, you should consider a lower respiratory tract sample in the form of a tracheal aspirate or a bronchial alveolar lavage in accordance with the Society of Critical Care Medicine. So they're already thinking about this when they were writing this paper. That we were going to have these sorts of problems, that the tests are unreliable and
inconsistent.
Right. They can't always be, I guess the technique is a finesse. I don't know. And so many people were doing it once we got overwhelmed that not everyone knew how to do it, I guess.
Yes, and then there were a lot of false positives, which really created a lot of havoc.
Yes. Yes, indeed.
But false negatives, and now this person has all the signs of COVID, but they're negative and they're not getting the appropriate treatment and then they decompensate, and then they're in the hospital and they're the ones that are dying. I mean, it was really a stressful time. It's gotten better. How's it in Florida? I know you're having some real issues with
getting a little better. Okay. Slowly but surely, it seems like we're having less and less ECMO patients, more and more of our COVID ECMO patients, a little bit less slowly and a little bit more. Remember, we used to actually have other patients a long time ago. We actually had, aspirations and flu and, SARS and stuff, all those things, and chemical inhalation. Yeah, so those patients have seemed to resurface to some extent.
Well, that's what I was just talking about you had a non-COVID ECMO patient yesterday. What was that like?
Yeah, I've actually had two. Yeah. Two in the same week.
I mean, when I guess so. When I got the call at 3 in the morning, we got to do ECMO, and I said, "Oh, COVID," and they said, "No."
No.
Wow.
Purely cardiac. Yeah, we actually had two.
So getting back to the immense brain wave that you go through during a transport. It starts off that you get called to the room, like in a perfusion case, to transport an ECMO to CT, right? COVID ECMO. And you're out in the hallway, and you don't have your PPE on, but you're starting to put your PPE on because once you go through that door, you better have full PPE on. So you go inside the door after putting all this on, you get the patient ready. The second you step outside the door, now all of a sudden, you no longer need the same PPE that you needed 3 feet inside the door, because apparently the COVID virus stays in the room waiting on the patient to come back. So then we go down the hallway with minimal PPE, and then we get in an elevator that is woefully smaller than the room that we had to go into with the PPE. So now we're really stuck in with the patient, and I'm not sure if an elevator has any ventilation whatsoever, by the way. So then you go through all the hallways with this same patient, just exactly like you said, Joe, all the way back again, and right before you go back in the room, you put all the PPE back on to go back how you started. So I think that it would be interesting to have a PerfWeb, Joe, on an infection control person who works in a hospital, whatever position that is, who derived these decisions, who came to these decisions. And I have a feeling that it's based on some reasonable assumption that you're in contact with the patient in the room, therefore you leave your PPE in the room and you go down the hallway and you come back, you're contacting the patient again, and you don't want to drag that PPE out in the hallway, although mostly none of that is actually true. I mean, you can contact the patient in CT and in the hallway as well. So I would really interesting to find out from one of these infection control directors, how they derived at this. And anyway, at the end of the day, I think we're going to find out there wasn't much different we could have done.
No, I don't
Probably.
think there was.
Mm-hmm.
I assume you're not doing this anymore, but we had started out, and you probably did too, when we had a known COVID ECMO, we were pap pursuing to just put them on ECMO.
Yes.
Were you doing that, John, in the beginning?
Yeah, sure, yeah.
And you're not
Whenever
doing that
you came
anymore.
in contact with the patient, it was full respiratory PPE of some time. At different hospitals that I worked at had PAP, or some we had different things, but yeah.
And you're not doing that now. You have a COVID ECMO. You're just putting on your N95 and your normal stuff and putting them on ECMO.
No, everybody has their own choice. You have your choice of doing N95, a duckbill, a full North mask, or a PAPR. You have your choice.
Oh, okay.
And most people have been assigned their own personal one. You have your own personal one, and some people have been allowed to go out and purchase their own actual face shield, like the North-South or the North mask, or even their own PAPR. So it's up to you, but you have to do one of them. You can't just go willy-nilly and say, I've been vaccinated, so no, we haven't been allowed that. But I will tell you something that changed here in the last week is our walk into the hospital temperature checks have been abandoned. You're self-temperature checking now for employees.
Well, I think almost all of our hospitals have moved to the iPad. You know, it's automated. You're checking your temperature. But I did notice, actually, I don't know if it was this week, but it was my first time back to a hospital I hadn't been to in a couple weeks. And before, we had to have, you know, a sticker or some sort that said you were screened that day, and there no more stickers. So I wonder if we're not moving to something like that. I know that they have greatly reduced the questions that they used to ask us. Now they expect us to do those self-evaluation at home before you come to work, and just showing up to work is your affirmation that you're not sick. You know, you haven't been exposed, etc. I remember in the beginning you couldn't even say you were. We didn't know how to answer the question if you had been. Now they say, have you been exposed without the proper PPE?
Right.
In the beginning, that wasn't a part of the equation. It was just, have you been exposed?
We must be highly advanced, because we stopped with the questions about 2 or 3 months, maybe 3 months after this all started. We stopped with the questions, but we were doing a different color sticker on your badge every day. And the only fun part of that was, if you kept putting a sticker on top of each other, you could actually build a little mountain of stickers on your badge before you had to peel them off. But then they stopped the stickers about 4 or 5 months ago, and they stopped the questions well before that. But we never did an automated temperature check. It was always the hand gun, and we just stopped with the hand gun about a week and a half ago, and it's saying self-monitor your temperature, and they offer you a mask. And if you have your own mask, you don't even have to take theirs anymore. So I think we're getting closer to almost normal again. Maybe within 6 months or so, I have a feeling.
Yeah.
I wanted to talk about the temperature. You said something about the ORs being a negative room for these
negative
COVID
pressure
patients.
rooms.
ORs are positive pressure rooms. By their nature of their design, an operating room is a positive pressure room. So when you open the door, right, airflow goes out, so other patients' infections from another room cannot come in.
Right.
So I don't know that any of our ORs, not that I've ever heard, were converted from a negative to a positive. Now maybe they were, but that's not an easy thing to do for your engineering department, to change a positive room into a negative room.
Well, we've seen it at, not specifically in the OR, actually. I hadn't thought about that. But in the patient rooms, you know, you always have a couple negative pressure for those isolation patients. But we have, some of the rooms have been converted, or there's just, you know, the sort of engineering parts that you need for that just kind of laying all over the floor. It looks like a unfinished, you know, some kind of unfinished construction project. Is that what you saw too when they were converting the rooms? Or
at some other hospitals I went to, they figured out something. It didn't look, it was unsightly, but they managed to figure out a way to blast enough air out of the window, actually, in some cases, to where it created a negative in the room. But at our hospital, it was absolutely, the engineering department said we could not do it. We'd have to, basically, you couldn't use the ICU for 6 months. We'd have to tear into the ceiling and the walls to convert a room into a negative room that was already a positive room. So we just went with some rooms being positive.
Yeah, yeah. Well, I wondered if, before we get on to, I have just a little bit more to talk about, specifically about what Joe had alluded to about delay of care. What are some of the things that we started early on that you actually think that are going to stick around, that we've actually, still implemented into our practice, that even after we're probably through this particular pandemic and concern, that are going to stay around as far as healthcare workers? Joe, do you want me to start?
Yes.
Well, I don't know if you've noticed, but a lot of hospitals have now implemented, even when they're COVID negative, that no one needs to be in the room during intubation except the person who is actually doing it. So everyone is asked to go out into the hall. Have you been witness to that?
No, I haven't been around that yet.
Yeah, and so
I haven't seen that.
I think that will probably stick around. I notice that it's a lot of times when the nursing staff or the scrub staff, they're taking that moment to go to the lounge, get their sip of coffee, go to the bathroom, but they're timing it during that period, and then they're waiting until it's clear.
I mean, and to me, I mean, I'll tell you what I think. I think that's the oddest thing, because that's one of the riskiest times of the operation.
Yeah.
Intubation.
Mm-hmm.
That's when things can go horribly wrong. You could have an aspiration occur. You could have a difficult airway. They can't get the tube in.
Mm-hmm.
They can arrest. They can code. And really, I would think that that's the time when you need to have more eyes
Mm-hmm.
and ears on the patient and the monitors than not.
Well, and specifically in one facility, I was busy, and so I wanted to stay in the room. I had more things to do for my prepping, and I was told I was not allowed, even with an N95 and goggles. So I'm wearing the protection, but I still had to step out of the room. Also, the face shields. That wasn't a thing before. People
Right.
had goggles or glasses, but I think face shields are going to stick around.
Mm-hmm.
Yeah.
Maybe so. I think so. I think some people are going to act one way. I think others are going to act another. And where are we as far as time? I don't want to mess you up.
Yeah,
do you have more slides
I
to
do, but I just, real quick, we'll just go, don't go a Joe length, just
Okay,
a real
I'll
quick
just
answer.
go real short. I'll just go real short. Okay. I think I see and feel and personally am experiencing real fatigue and not wanting to, if I get it, I get it. I've been vaccinated, and frankly, I don't know how I didn't get it, because I was managing these patients up close and personal for a very long time. I was exposed, I don't know how many times to it. I may have gotten it, was asymptomatic, don't really know, vaccinated now, but I am personally, and I think I see with my own eyes, a lot of fatigue in this, and people just wanting it to be, I'm done with it. We just need to do our jobs, take care of our patients. I want to go home at night and do whatever I'm going to do, or in the morning when I get off my shift, and we want to get back to regular, to what was considered our normal. Mm-hmm. Will we? I don't know. But I think that's what I see most of is actual battle fatigue, PPE fatigue.
Yes.
That's it, but precaution fatigue.
Precaution fatigue.
We're just treating everyone as if they're, they have Ebola,
yeah.
And they don't. So that's what I see.
Any thoughts, John?
I think what might stick around for an awful long period of time is the anesthesiologists and the CRNAs, and I see this now, they basically put their North mask on in the morning and seem to wear it all day long. Mm-hmm. COVID patients are not. The anesthesiologists and the CRNAs, they seem to be almost making it like that's what we're going to do every day, because we're right, they're in the worst part of it with all the intubations they have to do. I think that may stick around for quite some time.
I think the RTs are doing that as well.
Years probably. And then the other thing that I think is going to stick around is these dots on the floor, that you see everywhere. 4 dots on the corner of the elevator, stand here, the stand in line thing. And I think all your stores are going to take, you go out to the big box stores and the pharmacies and the supermarkets. I think those are going to stay on the floor, quite a long time. They're probably going to have to wear themselves out before they disappear. You know what I mean? So things like that, I think, are, and then you're just going to have the individual person, and I see it to this day. I get on an airplane, and a lot of people just wearing their regular mask that they bought on Amazon, and another person will have double mask, big, heavy, thick gloves. They don't want to touch anything, and so I think it's going to be your own personal, preference for a long time. And then, but I am starting to see. I went to a restaurant last night here in Orlando, and they didn't require any of the customers to wear a mask.
Oh.
Some people were, some people weren't. The workers still do. The waitresses and the bartenders, are still doing. But the customers, some were walking around to the restroom and back to their table, no mask. I'd say it was about half and half.
Wow.
So it seems to be slowly grinding, maybe back down to a little bit of a normalcy in some regard.
Well, I think Joe's correct. You said, it was perfectly said. We have precaution fatigue. And as something as silly as this is, if you wear glasses and you wear a mask, it's very difficult to manage all of that. If you're not, we've been in healthcare a long time, and we're kind of used to that fogging up of the glasses and figuring it out. But it's really annoying, and I think a lot of people have fatigue from trying to, my husband has fatigue from trying to be able to see with his mask on. He's constantly fidgeting with it, and so I do think that we are fatigued from, having to think about this all the time.
Agreed.
Okay, real quick, I'm going to get into, if you can put the slides up.
Oh, and you can draw on your slides, right?
Yes.
Okay.
Okay, I'll try to draw on something.
Okay.
We have a new toy. It didn't work last time. I don't know if you guys remember, but Joe is really excited about it. He really needs to use it. He's more.
No, I want you to.
Yeah. Okay. So just real quick, I thought it'd be interesting to talk about delayed care from the COVID pandemic and the impact on cardiac emergencies. And so I'm sure there's a lot of information out there, but I found this particular article really illustrates the point that I think you and I have both said, and John, I think you agree as well, that, so let me tell you about the article real quick. So this was an article published in the Journal of the American College of Emergency Physicians, and it was published January of this year. Title is The Impact of COVID-19 on Statewide EMS Use for Cardiac Emergencies and Stroke in Massachusetts. And it was authored by Dr. Goldberg. Okay, I'll just go over this briefly, but basically they were looking at to evaluate the impact of the COVID-19 on emergency medical services used for time-sensitive medical conditions. So we're talking about things that are true emergencies. They examined the EMS used for cardiac arrest, stroke, and other cardiac emergencies across the state during the peak of the COVID-19 pandemic, evaluating their relationship to the statewide COVID-19 incidence and statewide emergency declaration. So it was a retrospective analysis of EMS calls between February, here, I'll do this for you, Joe, February 15th to May 15th of 2020, and the same time period for 2019. The EMS call volumes were compared before and after March 10th. And March 10th is important because that's when they had their statewide announcement that they were in emergency declaration because of the pandemic. Their results, they looked at a total of 408,000 calls were analyzed. About 50,000 represented stroke, cardiac arrest, and other cardiac emergencies. The average call volume before March 10th, so before the statewide declaration, was similar in both years, but decreased significantly after March 10th by almost 19%, which is statistically significant, compared to that same time period in 2019. There were 35.6% fewer calls for cardiac emergencies during March 10th, and 12% fewer calls for stroke. Calls for cardiac arrest increased 18%. I broke that. Calls for cardiac arrest increased 18%. So they had 28 versus 24 calls per day. The calls for respiratory concerns also increased, but there was no significant association between statewide incidents of COVID-19 and EMS call volume. So their conclusion was EMS used for certain time-sensitive conditions decreased after the statewide emergency declaration, irrespective of the actual COVID-19 incidents, suggesting that the decrease was related to the perception instead of the actual case counts. These findings have implications for public health messaging. Measures must be taken to clearly inform the public that immediate emergency care for time-sensitive conditions remains imperative. Their study demonstrated that a significant reduction in the calls corresponding to the declaration, although the statewide declaration emergency was associated with the sudden decrease in call volume, they found no correlation between the actual COVID-19 cases and overall EMS contact. The statewide rise in COVID-19 incidents that followed was not associated with corresponding reductions in EMS contact. These findings suggest that overall EMS contact was likely subject to a greater influence by the public perception of disease threat than actual estimates of disease incidents reported over time. So they said there's several possible explanations, and that is decreased population mobility, so everyone's staying at home, right? And the fear of contracting the disease. During this period of uncertainty, patients seem to avoid emergency care owing to a perception that encounters with the healthcare system might increase infection risk. A national survey that was conducted in April 2020 reported that 4 out of 5 adults were concerned about contracting the disease in the ED. 29% avoid or delayed medical care because of the concern. Patient motivation is an important factor in EMS use. The decline in EMS use for these conditions during the study period is concerning and has implications for public health messaging, as they've said. They also said that the safety of receiving emergent medical care, especially considering the significant morbidity associated with delays in care, was affected, and that altruism may have also played a role as patients purposely avoided medical care for fear of further stressing what they believe to be an overburdened healthcare system, despite the low case counts during that time. That's it.
Yeah, wow. That's a really as far as I'm concerned, powerful article and commentary from those people. Very good, absolutely appropriate observations. And I think that, in time, we are going to find out that the death associated with non-COVID related treatable disease will exceed, and I've said this for a very long time now, and I still believe it to be true, and we'll see what the data bears out, but that the death associated with patients that did not have COVID, had treatable diseases, did not get care for a variety of reasons, is going to exceed significantly the death associated from the actual COVID-19 illness.
Right.
I believe that.
It was an article I chose not to highlight just for time's sake, but I remember reading a commentary, actually took it a step further and said that these deaths are now COVID deaths, but not from the disease, but from the, the after effects, the aftershocks of just what this pandemic has done to our healthcare system and in general to our society, because they weren't just looking at surgeries. Mm-hmm. They were also looking at the the social isolation and malnutrition of children, and all those sorts of things that have been in the news as far as the social aspect of
mental
this.
Health.
Mental health, exactly.
Mental health. I mean, suicide, drug abuse, alcoholism. The list goes.
Domestic abuse.
The list, exactly. The list goes on and on. And I think that the uptick in domestic abuse isn't necessarily just related to, because it's really true, there was a significant uptick in domestic abuse, but how much of that was that they were stuck with each other, they can't get away. I think that was one of the arguments, which I think is silly. I think it was just the already dysfunction of a relationship with the secondary stress of all of this.
Well, just the whole
not
world.
Just proximity.
Right. It's not just proximity.
No, but I think that this may have turned some very good people into some very bad people. We don't know, but again, we will find out. John, your thoughts on that? You live in a different state.
I think that spending more time around someone who can get on your nerves a little bit, and now all of a sudden you're stuck with them 24/7. But then you combine that. So I think there was some factor to that. I mean, if you've ever had a roommate in college that you got along with okay, but you wouldn't want to be stuck with them 24/7. You'd probably want to strangle them. And then you combine that with the fact that drinking and drug use was skyrocketing. So they're sitting at home, right? They're around someone that anybody's get tired of anybody after enough period of time. You can't do anything. You're drinking, doing alcohol. That's going to escalate it, right? So I mean, but the ripple effects. I think we talked about this a month or two back. The suicide hotline did a 12-month survey, and these are statistics. This is the national statistics of the 800 number was 400% higher year to date. I think they did it on October 30th. They looked 12 months back, and it was 400% higher the suicide hotline calls per day for people calling that number. And certainly the domestic side of it, the child abuse, all the other things. You couldn't go to the gym. You couldn't do anything. And fortunately, believe it or not, Joe, as stressful as you say it was for all of us, we were able to get up and leave and go to work every day.
Right.
We didn't have our jobs lost necessarily and be imprisoned in your own home because there was nowhere to go. I don't know if I could have dealt with that too easy.
No, I don't think I could have dealt with it at all. But I think, sort of circling back to the sort of the point of our lectures today, I'm having chest pain. It's probably just anxiety. I don't really need to go to the emergency room. I'm afraid to go to the emergency room. I'm afraid to call EMS, or I don't want to, as you said, the altruistic approach. It's probably really nothing. Let me not go because I hear
really
on the
busy.
news they're so overwhelmed. This is going to be okay. And the next thing you know, they have a big STEMI, or they die there. They don't even make it to the hospital, or they were having abdominal pain, and now it's a ruptured AAA, which is very low survival on that anyway, especially if it ruptures at home, and you're not in your delayed care and getting somewhere. Yeah, I mean, it's such a vicious cycle of, minor things, like I've got this lump, but it's really small. I can wait. Let me just wait. And then the next thing you know, they go from a stage 1 or 2 to a stage 4 breast cancer, and they have a terminal diagnosis. Never got COVID, but they died from COVID. They died from COVID without getting COVID.
Right. And we're a year into this now. And so think about that person who last March or last April, once really people started, kind of panicking, realizing that this wasn't going to just be something quick that ended. I'm sure they didn't realize or, even imagine that it was going to be a year later. And we've made, improvements. People are getting vaccines, sure, but they may still not have gone to the doctor.
Right. Absolutely.
So you're a year into whatever your problem might be.
Which could go from treatable to terminal.
Correct.
In a lot of circumstances.
Correct.
We've had 2 patients that I know of who were treated as COVID. They were negative, but they had the 5 tests, all negative, and all of their symptoms were basically being viewed as COVID, and both of them had heart attacks, one with a ruptured ventricle that ended up on, never got COVID, ended up on ECMO and transported to a center in need now of a durable VAD or potentially a heart transplant. And probably all they really needed was a stent.
Yeah.
And there was another patient very similar to that. So these are real issues, really serious health concerns. And you're 100% right, John. I mean, I can't imagine being locked in my house. We did get to go to work. So notwithstanding, I'm not insensitive to that. But from our perspective, everything we dealt with, which it changed from sort of routine, the patient comes in, we do this, we do that, this is what needs to happen, we go forward and we do it. And we had our occasional crash and burn where patients rolling in, they're in trouble, we got to go and try to save this patient's life. They happened now and again. That's the nature of our business. But most of what we did had a certain routine associated with it. Now, for the past year, and it is getting better, I certainly agree with that, but we went a long stretch of time where everything we did was an emergency. Everything we were involved, there was nothing routine. And so every patient was far more critically sick.
Yes.
And in fact, our elective procedures dropped off dramatically, and almost every case we did was urgent.
Yes.
We weren't doing a case unless it was urgent and then or emergent.
Yeah.
And so I think that, again, these are the things that affected me personally, and I assume all of the rest of our colleagues out there, wherever they may be from, unless they just shut their heart surgery program down, let's say a small community hospital, and then those patients in that community, I mean, the hospital may have done what they felt was the right thing to do for them and their staff, but that could have potentially been the worst thing to do for the people in that community, because how are they going to get to the next place where they could actually be treated? And I think that happened in several places that I am aware of a couple, but I'm sure it happened in more than just a couple.
And didn't you guys, for me, this stuck with me. It's still hanging around with me to some extent. In addition to what you just said, Joe, I found the whole enormous, tedious process of putting on all that PPE and taking it off and putting it on every time you had to go do anything at all. I found that to be so, undesirable after a while. You know what I mean? It was like carrying around another lead weight on top of your job you already have to do. The whole process of the whole thing, and then discarding it in the proper way, coming back in the room because you had to go just step out for 5 minutes. You got to do all that over again. And we had even codes, in the ICU where it took people a few minutes to get all that stuff on to come in the room to start helping out.
Yes.
It was very cumbersome, and I still find it to be unpleasant. I really think it added a whole nother layer of tediousness, and I really hope that one day it goes away entirely.
I know. I mean, even just something as silly as, remember when we were mask conserving because everyone was worried we were going to run out of N95s? Just keeping up with your bag or your Tupperware. There were just piles of things everywhere. Oh, this is Mike, this is Joe's, this is John's. You're just digging through trying to find your thing because you're now ready to go into the room and take care of your patient.
Well, how do you think I felt when I took my mask that had my initial on it, only to find out somebody else had the same initials, and we were each wearing each other's masks?
Oh, gross.
But they were the same size, so it worked out just fine.
Well, I guess that's fine. Or,
It happens.
There was someone's job in one of the ICUs when we switched from the disposable to the washable gowns. That was their job, was to roll the gowns up to stuff the carts.
Yes. I remember.
That was a job.
That was a job.
It was a job.
Okay.
And I have a question for you. I have a quick question for you. How many times in a row are you allowed to wear this N95? before you have to get a new one.
That's a very good.
Did anybody ever come up with that?
No.
That's a very good question, but I'm going to let you two debate that. I'm going to ask to be excused for 2 minutes.
Yeah. No, actually, we were just talking about that because now that there's no more mass conserving, at least not here, the hospitals are now wanting us to go ahead and discard them at the end of the shift. But sometimes I get one because they have the kind that I like, and I put it away so that I can make sure when I come back to that hospital, because we're not always at the same hospital or wherever I'm going to go, I have a clean mask that I know fits me well, and I had one in my bag the other day. It was new. I took it out and I had to discard it even though it hadn't been worn. So we went from one extreme of, I know I had a mask at one point for, a couple weeks of, 8-hour shifts almost every day taking care of these patients that I was putting back in my Tupperware, and to, I can't even take a N95 out of my bag without it considered being dirty. So we've gone right from one extreme to the other, but I never found out the answer for how long is an N95 actually considered effective.
Yeah, and what if you had worn your N95 as much as you said, but you never came in contact with the COVID virus on that mask, and you did it for a week or two, and technically I guess it's probably fine. But maybe you put on a new one, and unbeknownst to you, the first day, you got COVID on the outside of that mask. You would not know that. And so now you're going to wear that for a week or two, I guess.
Yeah.
But the likelihood of that one being far more dangerous than the first one, is probably exponential, I guess, if the COVID virus is still hanging out on the outside, or maybe the edge there of your mask, or whoever knows where it ended up.
Yeah, I mean, there's no cleaning of those masks. And then I worried about, when you're wearing them for so long, you're doing a lot of breathing in it, of course, and sneezing or whatever else you need to do that's getting that mask moist. And how long is it effective after that sort of thing? It made me think about they were never intended for multiple day use, and who knows if they were even really effective. I don't know.
Yeah, I guess they were, they're a lot better than the thing that you see going on everywhere in society. I think is doing almost nothing. It's doing something, but it's not doing much. But the airlines has now gone to, you suddenly cannot wear one of those gaiters over your face. You know what the gaiters are?
Yes.
The nylon neck things that everybody's doing.
Yes.
Well, I get on a plane the other day, and they're like, you can't be wearing that. And 2 days before, I was wearing that. You have to have, so anyway, I got a regular mask, and I sat on that plane, and I looked around. Every single person on that plane had wore some type of cloth, fabric, store-bought, on Amazon, at the grocery store. I don't know what those things are made of. They all have funny designs and colors. And, does anybody have any idea of the effectiveness of all these variety of things? Some look thicker, some look thinner, some fit totally different. I mean, whatever you make a mask and you put a nice package on it, I guess you're allowed to sell it and people can buy it, and I guess you're in accordance with the the laws, I guess.
Well, I went to the hair salon. I think it was a few weeks ago, and I had a mask, of course. I work in a hospital. It wasn't even because I could tell that they were handing out masks, and they were not cloth masks. So I thought, oh, they will appreciate me wearing an actual mask from the hospital. So I took out a clean mask. It's never been worn before. One of the ones I got on the way out of leaving a hospital to have for next time. And they saw me take it out of my bag. I mean, it's not bent. I mean, I'm still having to shape it for my face. And they said, you can discard of your mask there. We want you to have one of ours from our box. So, they were being very strict. And their mask was exactly like my mask. Just they, I guess, know that people are likely wearing those until they're not doing really anything at all.
They fall apart.
Yeah, they're
Agreed.
getting all fuzzy on the inside.
Agreed.
Yeah.
I'll tell you another thing that's evolved in our society from all of this that never existed before, and that's called mask litter, right? You see mask litter all over the place. parking
Yes.
lots, landscaped, areas by the grocery store, and this was a whole new phenomena that we never had before. But you've got mask litter. The other day, I thought it was a dollar bill or something laying in the grass, and I reached down and picked it up, and lo and behold, it's somebody's crumpled up,
Ooh.
mangled mask that was left there from about a week ago.
Good gracious.
Well,
Okay.
any final thoughts?
I thought that was an excellent topic.
Yeah. Well, you picked the article, so that's
I did?
good. The commentary, at least.
Oh, I thought it was that. Well, I think you did an excellent job
thank you.
explaining it and going through it and stimulating some, like we always have, excellent discussion around it. No, I don't have anything further other than I'll just tell anyone out there that's not medically inclined, that isn't medical, if we have any in our audience that aren't. If you get sick, you have chest pain, you have abdominal pain, you think that there's something wrong with you, please go to the emergency room.
Absolutely.
Don't sit and wait. We were overwhelmed. I mean, there's no question about it. But that's what our jobs are. So I would say that's probably my message to people. Anyone who may be watching that isn't medical, you get sick, go get help.
Agreed.
Don't wait. Okay, I think it's time to run the intro, which we should have done. I got my whole routine messed up this morning. Totally messed up. And whose fault is that?
Well,
Anesthesia,
it's
exactly.
It's anesthesia's
I
fault.
appreciate that so very much.
I like that.
Thank you so much.
The
I
production
agree.
staff is witty today.
They are. Okay, let's go with the Knowledge Nuggets intro, please.
All right, we're back.
And we're back.
All right.
Okay, John, all yours.
Take it away.
All right, you guys ready?
Yep.
Okay, so here we go with Knowledge Nuggets episode number 6. Today's April 7th, I hope, 2021. I'm your host, John Ingram. I have no disclosures on this topic or any other in the past or upcoming. And our motto here at the Knowledge Nuggets program is spend a little time and expand your mind. So we hope to give you a little nugget of knowledge in a short, fast period of time that will help you be better tomorrow, right? So this is our topic for this week is going to be magnesium. We're going to talk about magnesium. And of course, our format, we have a different topic each week, each episode. We're going to try to give you something you can take home with you so you can go into tomorrow's in your job and be a better clinician with a little bit of nugget knowledge. If you want a take-home slide, a slide you can take a snapshot of, you'll see a golden nugget in the upper right-hand corner there. You'll know that's a take-home slide. That information on that slide hopefully will be helpful to you in the future. It's just a short, highly impactful segment. We try to give you everything you want to know without anything you don't, about 12 to 15 minutes. Then we have always a little surprise at the end of that, 2 to 3 minute gem of the week. It could be absolutely anything of interest. Then we'll have the panel discussion as normal for about 15 minutes. And if you guys at home have any email questions or comments, questions, suggestions about a future show, please email me at john.ingram@perfweb.us, and I will answer every single person who emails me that at that address. So what is magnesium? So here's a golden nugget slide. Let's define it. Definition. Well, interestingly enough, Joe and Tammy, it's the 11th most abundant element by mass in the body. And it is vital to every one of our cells. All cells, magnesium plays a vital role. And about approximately 300 enzymes in our bodies require magnesium in order to function properly. Magnesium ions interact with our ATP, our DNA, and our RNA on a regular basis. Magnesium is required for calcium and vitamin D absorption, among other things. Now, I put this in green because not only is magnesium vital for organs, it's vital for plants as well. Magnesium is at the center of the chlorophyll molecule, just as iron is at the center of the hemoglobin molecule. This process keeps living cells alive and maintains the baseline levels of carbon dioxide and oxygen in the atmosphere. I'm talking about plants in that case. Just interesting. So what is the function of magnesium? This is also a nice slide you might want to take home. Magnesium is vital to the well-being of all organisms. It's utilized for signaling, enzyme activation, and catalysis. Chlorophyll in plants is similar to hemoglobin in humans. Chlorophyll converts water to oxygen. Magnesium maintains our immune system, bones, and glucose levels. And one thing you want to remember about magnesium and what it does, it's the great relaxer and keeps things running smoothly. If you keep that in the back of your mind while we go through these next several slides, that magnesium is the great relaxer and it's also the great organizer. It keeps things running smoothly. Magnesium stabilizes abnormal nerve excitation or blood vessel spasms, such as in the conditions such as eclampsia. So, what are the causes of low magnesium or hypomagnesemia? The causes would be, one of the causes could be excess alcohol consumption, because alcohol blocks the magnesium absorption in the GI tract. You could also have low magnesium due to large fluid loss, a lot of NG suction, diarrhea, vomiting, diuretics, excessive diuretics, antibiotics, and malnutrition could also be causes of low magnesium. It can also occur in people that are fed intravenously for extended periods of time. You need your GI tract to absorb the magnesium largely. If you have low magnesium, you would experience symptoms of an increased heart rate, tachydysrhythmias such as torsades and VTAC. In your muscular system, you'll have muscle spasms and numbness, muscle contraction. In your neurological system, you're likely to have confusion, irritability, insomnia, and maybe even severe cases, seizures. In your lungs, you would have difficult and shallow breathing. And in your GI tract, you might likely have an overactive GI system resulting in diarrhea, because, remember, magnesium itself is going to keep things relaxed and running smoothly. So a low amount of magnesium is going to be the opposite of relaxation and running smoothly. So what is the treatment for low hypomagnesemia? Well, IV would be magnesium sulfate or magnesium chloride, which is given parenterally. Magnesium sulfate IV, magnesium chloride parenterally. Your diet, you could have eat foods that are high in magnesium. We're going to talk about some of those. And magnesium orotate may be used as an adjunctive therapy in patients with severe congestive heart failure. This has been shown to increase survival and improve clinical outcomes and their patient quality of life. Now, what about hypermagnesium, or high levels of magnesium in the blood? This can be caused by diabetic ketoacidosis, it can be caused by antacids, renal failure, and also Addison's disease. Now, since the kidneys rapidly excrete excess magnesium, the kidneys excrete magnesium very, very efficiently. So oral intake based on magnesium poisoning in adults with normal renal function is extremely rare. Hypermagnesemia is usually caused by a loss of kidney function. So now, what would some of the symptoms be if you had an excess or high levels of magnesium in your symptom? Well, remember, magnesium is the great relaxer. Okay, so if you had a lot of magnesium, you would have a decreased heart rate and a decrease of hyperarrhythmias. You might even have too slow of heart rate causing dysrhythmias. You'd have a prolonged PR and QRS intervals, maybe even heart block. You'd have a slow, depressed breathing. And neurologically, you'd be drowsy, lethargic, in extreme cases, maybe even comatose. And in GI tract, you'd have hypoactive movement of your bowels. So what you're going to do, how you're going to treat high levels of magnesium? Well, if you took supplements based on amino acid chelates, such as glycinate and lysine, this would help absorb some of the magnesium. Hemodialysis is a big one. It helps remove, you can remove the excess magnesium quite well. If you will give somebody an IV calcium gluconate, this will help decrease the muscle irritability. And in your diet, you would eat foods low or without any magnesium in them. So what are some of the physiological effects of magnesium? When it comes to our nerve conduction, magnesium affects muscle relaxation through direct action on the cell membranes. Magnesium ions close certain calcium channels, which will decrease the conduction of calcium ions into the neurons. So as magnesium increases, more calcium channels are blocked and nerve cell activity decreases. Magnesium is amazing in that it can actually compete with the calcium channels. It will compete with the calcium to go through those calcium channels. We're going to talk about that in a minute. When in cases of hypertension, IV magnesium sulfate is used in treating, for example, preeclampsia. In diabetes and glucose, higher dietary intakes of magnesium correspond to lower incidence of diabetes. For people with diabetes or at high risk of diabetes, magnesium supplementation lowers their fasting glucose. So what about the effects of the biological activity on the ATP, which I mentioned earlier? So in ATP, adenosine triphosphate, this is the main source of energy in our cells, must be bound to the magnesium ion in order to be biologically active. Magnesium is so important in the ATP that it often is referred to as MG-ATP and not just ATP. That's how important magnesium is. Now, what about the calcium ion channel blockade I was talking about a minute ago? Magnesium ions in cellular biology are opposite to the calcium ions because they have a greater electronegativity and thus exert a greater pull on the water molecules. We'll talk about what that means in a minute. Magnesium, although it is also a +2 cation, just like calcium, it is a smaller, much smaller size ion. It's much, much smaller than calcium. So amazingly enough, magnesium is able to compete with the calcium channels that are designed to pass calcium through them. It actually can outdo the calcium in its own preferred channels and has been shown to prevent passage of calcium through their own channels. And it has been also shown to affect gap junction channels, forming electrical synapses. So in effect of, what is the recommended daily allowance of magnesium? This is kind of a gray area, by the way. I think it's the FDA is not really quite sure what your intake of magnesium ideally should be, but in general, for men it's about 320 milligrams a day, and women it's about 100 more, about 420 milligrams a day. But too much magnesium consumed at one time can cause diarrhea, but that will be very short-lived because remember your renal system, if it's working fairly normally, will remove excess magnesium very rapidly. So what are some of the good food sources of magnesium? Green vegetables such as spinach, and that again is because of the abundance of the chlorophyll molecules which contain the magnesium. But also cashews and almonds, pumpkin seeds, dark chocolate, soybeans, bran, and whole grains. And something, Tammy, you might find interesting, I'm sure you're a health food eater. Whole wheat bread has twice the magnesium as white bread, and that's because the magnesium is largely removed when the white flour is processed. So, too much magnesium makes it difficult to absorb calcium. As I was mentioning earlier, it competes with calcium very strongly. Low magnesium, though, from dietary deficiency is very rare. So now here's our conclusion slide. Magnesium is essential to all cells. Over 300 enzymes require magnesium to function, and magnesium interacts with our ATP, our DNA, and our RNA. Magnesium is the great relaxer and keeps things running smooth and easy. And this is because it stabilizes abnormal nerve excitation or blood vessel spasm in conditions such as eclampsia and so on. So you guys know that most of us probably put a fair amount of magnesium in our cardioplegia. Also, if you've ever been to a code where the person has a tachyarrhythmia, such as VTach or VFib, you almost always will see a milligram or 2 milligrams of magnesium given to the patient during the code. And that's because it slows your heart rate and decreases the tachyarrhythmias. It'll slow breathing. It'll slow your bowel movement. It relaxes the mind, gives you maybe even some drowsiness, and it relaxes muscles and muscle spasms. All right, so here we go with the gem of the week. And you know, David, this part will kind of run itself. So the gem of the week can be anything we come up with. It could be a trivia question. It could be how to interview, have a good job interview, maybe virtually or in person nowadays. It could be a career opportunity that's out there we could discuss, as we did about a month or so back. Could be anything from something happening in perfusion news, perhaps a product recall or a new product that's just being released. It could be something that we're celebrating during Perfusion Week. That wasn't very long ago, I believe we just had one. I could take a famous quote, which we did a couple weeks back, and talk about a famous quote. We can even talk about an upcoming meeting, which the New Orleans conference, which we're calling this year MediWeb, right, Joe? Is coming up in a week or so.
It's
so
the
spring,
our spring
episode,
conference.
Gem of the Week is, do energy drinks affect your heart?
Ooh.
Now, you guys know there is a ton of these out there, and they are very popular. They're everywhere, and they are made by a ton of different companies, and there's a lot of different strengths and different things in some of these. So, do energy drinks affect your heart? Well, Dr. Jonas Dorner, wrote a paper in 2013 in University of Bonn, Germany. It says cardiac MRI shows energy drinks increase heart contractions. Now, what he did was he used MRI to measure the effect of energy drinks on heart function in 18 healthy adults. Now, he took 15 men and 3 women, and mean age was 27 years old, and he performed an MRI on their heart before and 1 hour after they consumed an energy drink containing 400 milligrams of taurine and 32 milligrams of caffeine. And what he found was that the peak strain contraction of the heart went from 22.33 before consumption to 24.15 after consumption. And by the way, that's a pretty good increase. The peak systolic strain before was 1.18 versus 1.3 per second after. And those were significantly higher after consumption. So these researchers noted, however, there was a non-significant increase in peak diastolic strain rate. LV function, heart rate, and blood pressure actually did not differ significantly before and after consumption. So it seemed to be specific to the strain on the heart muscle. Now, Joe, right there where you and Tammy are, in 2018, the University of Texas Health Science Center in Houston found that having just one energy drink had a vasoconstrictive effect on systemic arteries. The researchers there analyzed the blood vessels, the large blood vessels, not heart vessels necessarily, but your large blood vessels, and 44 healthy University of Texas students, and then gave each of them a 24-ounce energy drink. They waited an hour and a half later. The students' blood vessels were significantly constricted, and they had decreased perfusion going through them. In 2016, there was a study where that found that energy drinks can and do raise blood pressure, and they also found that that would likely increase the risk of people having a heart attack and stroke. In 2017, a study showed that they did cause increased heart rate. And then another study also showed that there are dangerous heart problems that have been linked to energy drinks, even in young people. So there's our conclusion of does energy drinks affect your heart? You guys have any questions, comments, suggestions for a future topic? Please email me at that email address you see there, and I will answer everyone's email. And thank you, and it's time for our panel discussion. Magnesium, and do energy drinks affect your heart?
So, John, we do have a question from our audience, online audience, which is, how are the levels of magnesium affected when going on bypass?
Well, I guess that would be interesting as to what magnesium is in your prime, because everything, as you know, is going to get hemodiluted, right, to some extent. So I would say take a look at what's in your prime. If you're using plasmolite or maybe isolate, they probably have a pretty normal level of magnesium in them.
Let's see.
And
look that up.
I would say one
I've
thing
looked
that
this up
may be
before.
a little bit more important is, are you putting magnesium as part of your cardioplegia? I know in microplegia, whenever I've worked places where we use the Quest, every place I worked, we put a certain amount of magnesium in our microplegia. How do you guys do it there, Joe? In your plegia systems that you have there, is magnesium in a lot of them?
Yeah, it's a great question. On the cardioplegia, we've been shifting to Del Nido, but I know that PlegiaSolve has it. Plasmolite does have 3 milliequivalents of magnesium in it. And so I'm assuming isolite probably is very similar. If you prime with saline, it's going to have none.
Yeah.
We've given, 2 or 3, even 5 of magnesium before when we've taken the clamp off in the older days, and they would go into VTAC, and we would give the magnesium, and then they would shock them, and they would come out of it or whatever. So I think that was fairly common to have that happen. What's up?
The battery must be dead.
No, it's green. Okay.
So remember, one thing I was talking about is magnesium and calcium are kind of a little bit opposite effects, right? So when we take the cross clamp off and you want the heart to come back, what almost everybody does, gives a gram of calcium, right? But in your cardioplegia, you obviously would not have calcium, but you might have magnesium. Magnesium being the great relaxer, slows down the conduction, decreases the strain and workload on the heart, which is why in a code, if you have a person who's coding and they're asystole, you're likely not going to give the person magnesium. But if the person coded from VTAC or VFib, you're almost always going to see the physician who's running the code asked to give a gram, or I think it's a milligram or 2 milligrams of magnesium. Is that the dose? I've forgotten now.
Dude, I don't know. This is your topic.
It might be a gram.
I don't know.
This is your topic.
This is your topic, not mine.
Yeah, I know, right?
So I guess we should probably look that up.
So,
Well, John, while he's doing that, I'll just speak from my personal experience. I know you mentioned that I have an interest in healthy eating and wellness, and
1 to 2 grams.
1 to 2 grams.
1 grams. I thought it might be grams.
Yeah. But we're encouraged from just a working out standpoint to take magnesium for muscle synthesis, as well as taking it in the evening because it's a relaxant and it's supposed to help you sleep well. And you just went over that, so that's interesting to hear that. Because I didn't really have any data on that, but a lot of people do talk about taking a magnesium supplement in the evening if you are trying to increase your muscle mass.
Absolutely.
Yeah.
Yes, absolutely. So yeah, I think, and to increase your muscle mass, you take the magnesium in the evening?
Well, I don't think it matters when you take it, but since magnesium...
Or is it just to relax? So
it does 2 things. It's supposed to be a sort of natural sleep aid, and then also it helps increase muscle mass because it's involved in muscle synthesis.
I get you.
You see?
Okay, yes, I understand. Yeah, so exactly. I think there is magnesium, certainly not calcium in cardioplegia, but magnesium. I know in the microplegia, the Quest system, that has magnesium and potassium as your 2 fluids to give your additives. As they call it.
Yeah.
I think treating the tachyarrhythmias with magnesium is common.
Well, I used to always give, as soon as the clamp comes off, lidocaine and magnesium.
Yes.
2 grams of magnesium and 1 to 2 sticks of lidocaine. kind of just depending on the patient's size.
Okay.
And I still have some anesthesia that like that, but I have seen that where it used to be commonplace where I did it all the time. I have seen that less and less when the clamp comes off to just automatically give the magnesium.
Mm-hmm. Yeah. Is
Yeah.
that better, guys? Is it working now, David? I was pulling on the cord.
And John,
Sorry.
are you still are you guys doing that out there with your bypass cases with the magnesium, or that's not common practice anymore?
Yeah, it's still pretty common to give magnesium places that I go. Magnesium, I think it does. I think it helps. I think it helps a lot. I think, if you have a cardioplegia system, though, whatever technique you're using, and a lot of people now the hearts come back, normal sinus rhythm on their own.
Yeah.
I think years ago, if you remember back years ago, Joe, in the 70s, 80s, and 90s, we had to defib by everybody. Nobody's heart came back automatically, it seemed like. But now that I've worked places where it was in a very high 90 percentile, whatever plegia system we were using, that the hearts just come back on their own. And probably because of that, I wouldn't be surprised if we're seeing a less use in those cases of magnesium, because the people aren't having, we would have to defibrillate the heart 2-3 times sometimes. And I think years ago we wouldn't even know that magnesium was going to help that much. I don't recall many years ago giving magnesium. We might give a second dose of lidocaine and keep shocking the patient endlessly until we finally got them, heart to actually start beating again. But I don't recall giving magnesium 30, 40 years ago.
Now, is magnesium something that you look at when you pre-op your patients for bypass? Because I know it's something I look at, but I notice it's not on most chart formats. People aren't really writing that down as a pre-op, but I came from an institution that was really interested in the pre-op magnesium, and if it was low, if it was below 1.8, you were automatically giving magnesium as soon as the patient rolled in the room. Anesthesia was just to start out with a normal range magnesium, since you're likely going to be diluting them.
Do we even check it on pump anymore? Do we even measure it?
We don't measure it, but I always try to find, if a full lab panel was done, I find what the baseline magnesium was.
Right. But, in answer to this gentleman's question, or this colleague's question, is as far as our prime is concerned, if we don't measure it, we measure calcium, right? But we really typically don't measure magnesium levels. And so I'm assuming that the reason for that, and again, I don't know for sure, but I'm assuming the reason for that is that it just is not, it doesn't change that much for whatever reason.
The handheld devices don't seem to have that as an option. It's not something that's being tested.
Not routinely measured.
No.
So it may be one of those things, if it's in such abundance, as you had elucidated, that perhaps it just doesn't really change that much. And if you need to give a gram or two, it's not a big deal. Just give it and don't worry about it, that it's not a problem, unless you're asystolic or something like that.
Right.
There's some other reason why you wouldn't. It would be contraindicated. But in answer to his question, I think, John, you answered it, which is look at the consistency of your priming solution. You are likely going to, if you use something that is non-magnesium containing, that you will dilute it. So if you use saline, you're going to dilute everything.
Yeah.
If you use isolite, plasmolite, or one of those other acetate-based Normasol, same thing, then you're going to have whatever is in there is what's going to be in your prime. And maybe we should monitor it. I really don't know. It was an interesting topic. I learned a lot about magnesium that I didn't know. I'm not 100% confident that I'm going to care tomorrow, but it was good.
I'm a fan of magnesium. I like the talk, John. Thank you.
I'm not sure I'm going to care. And I was also thinking about going and getting myself a Red Bull. I'm really tired.
Well, I was thinking about the energy drink stuff because I partake in the energy drinks.
But do they have magnesium?
I don't know. I'll have to get back to you guys on that. But you didn't have my brand of energy drink up there, so maybe I'm safe.
What do you drink?
I like Bang.
Bang? No comment. Okay, so
I didn't name it.
with all of that said, with all of that said, John, I think
Joe, you might need that Red Bull after all.
yeah, it gives you wings. Okay, that's all I know. Red Bull gives you
Oh,
wings.
gosh.
And they do some really neat sporting events and
They have
air
neat
shows.
They have
and-
neat sports spokesmen.
Yes.
Or product spokesmen.
Yes, they do. They are great. They are absolutely great. Okay, John, what's your topic next week or next next program?
Next time. It's not
Yeah,
next
next
week.
time.
Well, let's see.
Well, actually, you're going to be here.
It
You're
is
coming.
by Ballaruden. By Ballaruden.
Oh, that's going to be a good one. I like
Oh,
that
yeah,
one.
that is.
You're going to be here, right? You're coming. You're coming for the conference on the 14th.
In studio?
In studio.
John's coming to the studio.
Yeah, John's coming to the studio. You're going to be here on the 14th. When are you coming in?
Well, first you told me to come, and then you said you'd rather me Skype, and now you're telling me to come. So I thought you wanted me to. You told
You're
me to.
really confusing your guest.
Which do you want to do?
Let me look at my schedule, see if I have time. I'd love to come in. And let me see how I blocked off my schedule. I think I probably could.
Okay. I don't know
Okay.
why I said that, but I don't know. So I went back and forth. Is what you're telling me? Okay. Well, let's figure it out. Let's make a decision. But I know you're doing 2 new technology talks on April 15th. You are doing. You've got anticoagulation-free ECMO. Does this improve outcomes? That's going to be very good because we just had an experience where we're using not zero anticoagulation, but we were using very low dose, I think 40 units of Lovenox, Q12 hours, and a small amount of Plavix and aspirin. But our PTTs were all in the high 20 range.
Yeah, like 29.
And the patient had an intracranial hemorrhage.
Really?
Yes.
Still had a hemorrhage.
Still had a hemorrhage, an intracranial hemorrhage.
Mm-hmm.
Small one.
It wasn't that small. They had 6 centimeters of deviation
Hmm.
in their brain. It was 4
Oh,
independent locations.
I didn't realize that.
Mhm.
That's significant.
Yeah, I was very disheartened by that. But interestingly enough, the patient is awake and moves everything, and it is seemingly is in an area of their brain that is really not affecting them that we can see. They're on ECMO and extubated. We have 2 patients now that are on ECMO, but they're needing full support on ECMO, but extubated. One's on BiPAP, and the other one is on high flow.
Well, from my research so far into doing that talk, I can tell you that the number of places that are going down the path of less and less anticoagulation for VV ECMO now, not VA ECMO, for VV ECMO, going down the path of less and less anticoagulation, and even no anticoagulation is growing very, very rapidly. And I'm sure that at least the bleeding complications have dropped off remarkably.
Sure. Mm-hmm.
And it doesn't appear as though the clotting complications have actually improved very much at all. So a lot of people are discovering, because bleeding complications on ECMO are just constant seemingly.
Yeah.
And when you get to the point where you're saying we just cannot give this patient any more heparin, and then you go, wow, okay, we start improving our bleeding complications. So, but however, having said that, COVID has thrown a monkey wrench into that because those patients are hypercoagulable.
Yeah.
Mm-hmm.
Yeah.
Mm-hmm. Yeah, and I've heard that several times, and I know that we've had a few patients that we have seen in the hospital, not necessarily on ECMO, but I haven't seen the hypercoagulability that everybody talks about in all of these COVID patients. I haven't seen it. Have
That
you?
one patient that
One patient out of how many?
Yeah, but that was really bad because we were even heparinizing, full heparinization at that point, and we had a lot of weird things going on with that circuit, and we really just think it was. That actually leads me to my question, John. Have you heard of anyone post ECMO care taking these oxygenators or circuits and flushing them through with a clear prime and then trying to measure clot after this no heparinization or very low anticoagulation Because I think
Well,
I would find that interesting. Just to,
even with people who use 100% heparinization, 100%
well, I
of
know
your
there's
oxygenators will
going
have
to be
clots in them.
clots, right?
That's
But
been studied.
I wanted,
You cut them in
would,
half. There was, before COVID, there was about 2-3 years ago, I went to a meeting where there was no such thing as, much people not using anything but the normal, pretty high dose of VA ECMO anticoagulation. And they had that same question. They took 100 CardioHelp or Quadrox oxygenators and sawed them in half, and 100% of them had clots, multiple clots inside the fibers.
Right. I know there's going to be clots, but I wondered if there was any kind of comparison done between, I guess you could compare to the heparinization oxygenators that have been used compared to these non-heparinization, because I'm really not seeing, of course we can't see inside the oxygenator, but around the connectors or anything, I'm not really seeing any more fibrin or anything.
Well, no,
If you
not.
keep
That's what
your-
I said. I'm not either, really. I don't.
If you keep your flows up, which most of the time these, COVID VV ECMOs, they got to have a pretty decent flow. And our rule of thumb is preferably 2.5 liters a minute and above, and for sure 2 liters a minute. And if we have to go below that for any reason, we start saying we need to put a little heparin in on this patient. So if you keep your flows decent, it's not so much of the oxygenator, it's most of the time at the cannula sites that which are not biocoated most of the time, right?
Yeah.
So that's where it seems to be the problem. But now that you mentioned that, I don't see the fibrin around the connectors very often either.
And I remember when I first started doing ECMO, a long time ago when I was doing neonates, I remember that was one of the things we really checked for, and being a new perfusionist, you're on top of all of those sorts of things, and I remember seeing it a lot, and a lot of those circuits we would use for a very long time. We weren't doing a lot of circuit changeouts necessarily, but I remember seeing fibrin strands kind of frequently.
Yeah, and that's something that really bothers me. It is a reason to not, even though we may not see it. We go around in circles with my philosophy of changing the circuit more frequently versus not. And we can probably debate this forever. But I think that I like your idea. We do a lot of ECMO. John, you do a lot of ECMO. Maybe we can commission some kind of a thing where we get these oxygenators analyzed. What I would do is, instead of cutting them open, which can be quite, messy and difficult, is to put them in a CT scanner. And I actually have a CT of an oxygenator. I think Dr. Kravitsky, when he's here next week, next Friday or Saturday when he gives his lectures, is going to have some interesting data on that as well, because the ELSA meter not only checks for recirculation but also for intra oxygenator thrombus formation.
Right. That's what I was going to lead into, is that if you could then compare to, just for the data alone, but then also run side by side two of the same types of oxygenators, one with some clot and one without, and then demonstrate it with that ELSA meter side by side. I think that would be really.
I think we're going to do those kinds of simulations, actually.
Oh, that's
So I think
exciting.
we're planning on doing those kinds of simulations. I think you're going to see some very interesting stuff with this guy. He's really bright. And sometimes a little difficult to understand. He's got a strong Russian accent. But really sharp guy. And really knows this stuff very well. Question for both of you, and I can answer it first, and then you guys can add in. I've got a question on how do we manage addicts and edematous patients on CPB. So as far as the addicts are concerned, that's an anesthesia problem. They have to treat their,
you just have to know they're going to use more.
They're going to use more narcotics for anesthesia, pain relief, or whatever it is that they do. So from our perspective, from the pump perspective, it really doesn't affect me at all. as far as I know, I've never even given it consideration. I just know they have higher anesthesia needs, and that's somebody else's domain. As far as edematous patients are concerned, I think it's the reason. What's the reason for the edema? If it's just total body fluid overload because they've been in heart failure or they've had low oncotic pressure, they're malnourished or whatever, their albumin levels are low, their chyloncotic pressures are low, or whatever it may be. You know, I mean, of course, you don't want to do this if you're not on pump with a reservoir because you can really hurt somebody. But I simply, as long as I have a reservoir, I can aggressively treat the edema, pulling the fluid back in by raising the COP, giving plenty of albumin, give mannitol, whatever you need to do.
I was going to say, you could summarize that with albumin and mannitol.
Yes, and use aggressive ultrafiltration. You know, we did a patient yesterday.
Or Lasix, I mean, you know.
Well, I mean, this is the thing. I don't think people really understand this, and I'm going to, well, you could use Lasix, but if you're on pump,
right,
I'd rather use ultrafiltration. Sure. You know, Lasix is a great drug if used, you know, when it's needed, but it is itself nephrotoxic. Not only that, it's not controllable. So you give somebody Lasix, the kidneys are going to put out what the kidneys are going to put out from that loop diuretic, okay? So as the diuretic works, the kidney is going to work correspondingly, depending on the health of the kidney, how much you gave. There's all kinds of external factors, and the drug itself is nephrotoxic. So here you're using a drug that's not only are the kidneys being now perfused, usually with a lower hematocrit and lower DO2 just because you're on pump, and you're going to give it something that's going to, in an already hypoxic environment, a drug that's going to make it work even harder and consume even more oxygen. And I think that the potential risk of creating AKI from just giving Lasix exists, and I don't like it, I don't believe in it. That's not my preferred methodology. I think we have very good mechanical methods for achieving what we're trying to achieve that work very well, whether it be CRRT or just ultrafiltration on bypass. So if you do it and you don't have a reservoir, vis-a-vis you're on ECMO or you're just in the ICU, and let's say you're going to just hook up a simple scuff unit, and you give a patient, you correct a patient's oncotic pressure or osmotic pressure very rapidly and pull a bunch of fluid into the intravascular space to get rid of it from the extravascular space, the tissue, you can put them into heart failure very quickly. Now, and that's very dangerous. You can actually harm somebody that way very easily. With a reservoir, it's not as big a problem. But yesterday, we did a hyperkalemia, minimally invasive mitral valve without touching the aorta. It's a technique that I popularized some time ago, and we're using it more and more frequently. I'm very proud of it, actually.
It's pretty incredible.
It's something that I did in my career that I feel really good about. However, and with that said, this patient had long-standing mitral valve disease, had a very large enlarged heart, had very high pulmonary pressures. In fact, our pulmonary pressures were about 60/40 before we actually started the procedure. We did 15 liters of replacement to get the potassium out after the hyperkalemic technique, but we actually ultrafiltrated from the patient 23 liters, if I remember correctly.
Correct.
So there was a 7-liter, now you have to take some of the prime out of that or whatever, so let's just say it was an additional 5 liters. I'll be a little conservative. I took 5 liters of water, plasma water, tissue water, out of that patient. So this was and this patient came off with a PAD, I think of 18 or 20 versus 40, so half. Heart was working great. Patient was extubated that evening and did fantastic. So how I deal with an edematous patient that goes on bypass for whatever reason is, one, I want to know why are they edematous, what's the reason for it, and if it's something that is treatable vis-a-vis low oncotic, osmotic pressure, hypoalbuminemia, whatever the case may be, I'm going to treat that, get that fluid pulled back into the vascular space and get rid of it. And it is clearly, in my opinion, much easier to give volume to put it in than it is to get it out. So even if they're a little dry going to the ICU and need some fluid resuscitation as they redistribute, I don't have a problem with that. I think that's much easier to do. You just have to know it and be prepared for it.
Well, especially if the patient's going to be on bypass, it's a prime opportunity to easily remove volume versus keeping that volume and then the patient holds on to it and becomes edematous in the ICU. Then you don't have bypass. You're going to have to do something else. Lasix may or may not work, as you said.
Yes.
So now you're having to do another invasive procedure of putting in CRRT, let's say, where you already had the opportunity to take care of that proactively in the operating room.
Well, and this is another thing. You know, I mean, I realize we've morphed off all of these topics, but this is another thing. If you look at a patient, and when my computers were stolen, I lost these pictures, which upsets me to no end. But when you look at a patient who is grossly edematous, they have pitting edema in their legs and their eyelids look like water balloons, their earlobes look like water balloons, you know, their tongue is hanging out of their mouth. They're grossly edematous. It's not just their body that you can see that is like that.
Their
All
organs.
of their end organs, their gut, their heart, their lungs, their liver, their kidneys, everything has that same level of edema, which is horrible for perfusion because it increases the tension of your wall tension on everything, the tissue itself. And so your microvasculature basically doesn't even get perfused on these patients, and they just are, they're constantly ischemic. You have to fix that problem, and you can't wait and hope giving Lasix is going to help. You have to treat it aggressively.
Now, what was that device that you had that looked at the microvasculature?
Yes, it's the dark field side stream camera that looks at the microcapillary circulation.
Did we ever compare an edematous ECMO patient, let's say, their tongue, because it's so easily accessible?
You do it under you have to do it under the ridge under the tongue.
Were you able to compare a visibly edematous patient to a regular, you know, fluid balanced
yes,
patient?
Yes, that's been done by many people. I've done it myself as well on patients.
And was it really evident?
Remarkable. It's absolutely remarkable. In a normal patient, a euvolemic normal patient, you can see the microcirculation. It flows very nicely.
And it's just the little cars, because that's what it looked like,
the box cars
yeah,
going through.
They just look like they're really moving, right?
Very evident that it's normal. Normal really looks normal. But abnormal really looks abnormal,
well,
and you can see that's just, there's no
some of them look
flow.
like it was just like a still picture.
Yes.
Not even a video.
Yes.
Yeah.
Yes, absolutely. And you can see it. You can see you can literally see all of this. But of course, you know, it's somewhat technique. It's a little more difficult to use. There's some level of just it's academic when you use those devices.
No,
the micro scanner.
Yeah, no, I was just curious in
I loved, but
comparing
yes, we
it
have
for our
compared it.
discussion.
And you can find those videos online, as a matter of fact. So those absolutely
That's the dark
exist.
field, right?
Yes, side stream dark field
Side stream,
imaging.
yeah.
Yeah. And it's I got the name of the company. It's Dr. Keshan Mathura.
Yeah. Mathura.
Microvascular scan. You can find it. Yeah, I can't
something.
remember,
Okay,
but
anyway.
I would definitely look it up.
John.
Yeah, so you guys can tell me if your mindset is different or similar to what I'm about to say. From my very first day in perfusion as a perfusionist, doing a regular case, I don't think I've ever thought to myself, no matter what the patient is, I've never thought to myself, I don't need to be conscious of this patient having too much fluid on board. Let's talk about the kind of patients that we're dealing 99% of the time. It's a valve patient. Now, whether that's a left-sided valve or a right-sided valve, there's tremendous fluid backup that has brought that person to the OR, chronically, 3 months, 6 months, 2 years. What about the 90% of the patients that we do with coronary blockages? They're in congestive heart failure. This has been a long, slow process. 80, 90% of people that come to us, by the time they get to us, their ankles are somewhat swollen for a period of time. Their hands are somewhat swollen, which, as you just said, Joe, that's not just there. It's a lot of other places. So 90%, maybe even 95% of our patients are valve or coronary, have a poor functioning cardiac system whereby it's causing fluid to be pushed into either the lungs or systemically. Right. Secondly, the minute they came into the ER and to the OR, the ER and the cath lab and got under anesthesia scare, what did they get? Volume, 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 right? Because they hook up an IV in the ER before they even ask any questions, they start giving you volume. Yes. By the time they see us in the OR, all of those things, 95% chance, all of those things have happened to them. They've got fluid on board. Now, maybe it's only 2 or 3 or 4 liters, but most of the time, it's way more than that. Then we're going to put prime, right? We're going to prime the pump, and that prime needs to come off at some point. But not only that, that prime is going to hemodilute and lower their osmolarity unless you prime with mannitol and albumin. Then you're going to give cardioplegia. Now, you could be giving microplegia, and it's not going to add volume. But if you're giving any type of cardioplegia that's not microplegia, there's an additional volume there that you're giving. Anesthesia does not turn off their drips for very long or their meds for very long, which is all fluid-based input to the patient. A lot of these patients have some form of poor kidney function. They're not removing the fluid. So I don't think I've ever thought to myself, oh, here's a patient that I don't need to be very concerned about. And one final thing that people forget about. All of those things I just mentioned, even if none of those things are true, just the period of time that you're on pump with a non-pulsatile flow, that in and of itself causes fluid to shift. Regardless of the osmotic pressure, regardless of what you prime with, there is a strong tendency for fluid to shift in an environment of a non-pulsatile flow, which all of us are pretty much doing, right? So all of these things put together all say we have more fluid in the patient than we need. So to me, you should always be looking at a very high osmolarity that you can do on your prime. You should be looking at a hemoconcentrator taking off any excess fluid that you have the opportunity to take off. And then you have to think to yourself, if I ever did overdo it, which I'm not sure you could too easily, but maybe, you can just drop some more back in. If you're coming off pump and you're low on volume because you need a little more, that's as easy as popping a clamp off and you put another 400 or 500 cc's in because maybe you overdid it or whatever. But here's the other thing. When it comes to Lasix, I'm not a fan of Lasix. I'll tell you why, because years ago we did prime with that. It's very hard to control, but the Lasix most of the time remains for many hours into the post-operative phase, and the nurses are chasing their tails trying to keep fluid into the patient because you primed with, we used to prime with 40 milligrams of Lasix, which is probably quite a bit. And for the next 12 to 24 hours in the ICU, those nurses were chasing potassium and they were chasing fluid because the kidneys were just cranking out, hundreds of cc's an hour. So I'm not so sure that Lasix is too broad. It doesn't work just for the time frame we need it. It stays around way too long. And now we start affecting someone else's job, most likely in a negative way.
Agreed with you. So one of our colleagues from Egypt says that they just filtered off using ultrafiltration on pump 13 liters.
Oh, wow.
And I've seen that before. I have seen that before. I've done that myself before.
Wow.
But that's remarkable. That's a lot.
That's a lot.
That's a lot. And you'll hear people freak out over that. They'll be like, that's oh my God, that's too much. You're going to put the patient in renal failure. All of these things, and I've tried to explain this to people, and John, you could maybe help me with this. If I'm flowing 5 liters a minute, and I have the heart completely empty, and I have a reservoir that has 600 cc's in it, and I give albumin, the patient's just massively fluid overloaded. I give albumin, I do various different things, I get a bunch of volume back, I start pulling volume out, and the volume keeps coming, and I keep taking it out, and the volume keeps coming, and I keep taking it out, but I'm still flowing 5 liters. and before it's over with, let's just say I had a higher level than that. Let's say I had 1,600 cc's I started with, a little higher, and a hematocrit of 20. I didn't give the patient any blood. I gave all that albumin. I pulled out, let's say, 8, 9 liters, 7 liters, 13 liters, whatever. I'm still flowing 5 liters. The heart's still empty because I'm on pump and I have a reservoir. Now my reservoir volume is only 800, okay, and that's all they're going to need to come off pump with.
Right.
Have a hematocrit now of 25. I'm actually delivering more oxygen. Somebody help me understand how that puts a patient in renal failure. Anybody. I'll buy anyone dinner for 2. I don't even have to go to Trulux. I'll even do your transportation if you can show me how that causes renal failure, because I know you can't. How? Help me. Have you ever heard that?
Yes.
Yes. John, have you heard that?
Yeah, there's a couple studies that came out, and they're very poorly done. Unfortunately, they were not published in the perfusion literature. They were published in the cardiac surgeons literature, and now they planted the seed in the cardiac surgeon's mind that the hemoconcentrator is somehow causing AKI, and then they tell their perfusionist, don't use the hemoconcentrator because it's causing AKI. The perfusionist isn't going to argue with them, so they say we can't, and they start repeating. This has been going on for about 10 years now. They start repeating to other perfusionists, oh, don't use the hemoconcentrator, it causes AKI. Meanwhile, that doesn't cause AKI. It never has caused AKI because the treatment for AKI in the ICU is CRRT for many, many hours and days, which is the same thing you're telling me caused the CRT for 2 hours in the OR. And by the way, those are the exact same filters. Years ago, they were different, and you can make an argument, well, the CRT filter was different. They're not. They're exactly the same now, right, Joe? It's just a matter of the application. So if you're causing AKI on 2 hours of bypass, and the cure for that AKI is 80 hours of CRT in the ICU, you can't tell me that that doesn't make any sense.
No, I can tell you that it doesn't make any sense. Yeah, I
Right.
can't tell you it doesn't make any sense. I can tell you it doesn't make any sense.
I think he's tripping over semantics of how you phrase that. He agrees with you.
Yeah.
Exactly. Exactly. Okay. All right. Well, great conversation today.
Yep. Real quick
We
about
went
our
from-
next week.
We went from, oh yeah, next week. So why
Yeah.
don't you tell everybody?
Next week we have our spring conference. Yay!
Yes, it's going to be great.
It's a multi-day, multi-studio, multi-location, lots of faculty. How many different speakers do we have?
A lot.
Lots. Lots of people besides.
We have Deb Adams. We have Ann Greccio. We have Dr. Kravitsky. We have Matt Warhoover coming from Vanderbilt, of course. We have John is going to be there. You and I. Did I say Deb Adams?
Yes.
Yes. We have
We've got some interesting
Min
topics.
Tran, Mike Brown, Patrick O'Toole,
Kimberly
Dr. Duvall, Kimberly
Sperlin.
A lot.
A lot of people. It's going to be a great time. So I really hope that everyone.
And great topics.
Yes. Interesting topics. Not just, we're not going to just be talking about ECMO or renal failure or some of our
There's
favorites.
a lot about ECMO.
But it's not just the usual hits. There's going to be some interesting things in there, and I hope you will join us.
A lot of ethics.
Yeah.
We're going to be talking about a lot of ethics.
We've been wanting to do a program like that for a while.
Well, we have been, and I've been very troubled by some of the decisions that have been made over this past year with how we have the decision algorithms to treat patients one way versus another way.
Yeah.
And I think that we're going to have some very interesting discussions about the ethics of healthcare. We're also doing some presentations on how to manage your health, because you've managed your health far better than I've managed mine during this period of time.
Yeah, we're going to have some great topics, and I believe we're approved for 26 CEUs.
26.2.
26.2.
Category 1 CEU by the ABCP.
Yeah.
Okay?
So
Very
great.
good.
Yeah, great
Well-
topic today, John. I really enjoyed the magnesium and loved having Vanderbilt on with us today.
That was fantastic, our inaugural.
It was worth
John,
getting up early, for sure.
remember you said, what are you doing new? Remember when you said that to me a few
Yeah, okay.
programs ago? Okay. Is there anything else I need to do now?
I believe the response is, you brought it.
So we just need to expand that into even more places. We have Vanderbilt. We're looking for other institutions on a worldwide basis.
Yes.
We can learn from what would be international to us colleagues, because look, this guy from Egypt, he is continuing to talk.
And it's not just about the education, it's also about the fellowship and community. We're all in healthcare
Absolutely.
together, and I think we can all really enjoy each other's company in addition to learning some things.
Absolutely. There's no question about it.
And Joe, can I say something, you guys?
Of course.
I hope if any there's any perfusion school staffers or directors that are watching or ever watch your show, I would really hope that there is some way that they would consider getting their students involved in some way with the perfusion education here, the PerfWeb shows, because look at all of us right here. It's been an awful long time since the three of us have been in school. I would love to have 2 or 3 students panelizing with the three of us, and the amount of stuff that we could share with them, but the amount of stuff that they could share with us about what they're being taught on the cutting edge and the front lines of all the new things that are happening, all the new techniques that they're seeing, what they're being taught, why they're being taught, like we just brought up this AKI issue with the hemoconcentrator. I think there's some of that going on in the schools. The interaction of what we could learn from them, what they could perhaps learn from us, and the camaraderie of the generation difference there, I think would just be explosive, and I think it would be very beneficial to any perfusion school program that would think about having some type of, interaction on a routine
collaboration
basis.
Yes,
Maybe there's one class a semester where the students have to participate in one a month of the PerfWebs, be a panelist, maybe even present a student paper. All these students in these schools now are required to write some type of student research paper. We'd love to hear it.
We would. I mean, and what a way to really be inducted into our profession is, to be welcoming to these students, and also possibly encourage some of them to go on to do other leadership roles wherever they may end up.
Absolutely. I think the more education we are able to bring, the more of these discussions, the more people and places that are also doing this, is going to be important as well. I welcome others that want to also do this. My only cautionary note is that it needs to be done professionally and done right and done well. You have to bring value at the end of the day. That's what it's about. Okay, it's about us talking together, not me talking to you. There's a big difference between that, I think, and that's what I think you bring. I think, John, that's what you bring, a sense of collegial inclusiveness.
Right.
And I think that's what's so very, very important in our profession.
Well, we're not here to teach a lecture. We're here to share knowledge and then discuss and hopefully expand our mind, right? Isn't that what, John? That's
Absolutely.
what you always say?
Spend a little time and expand your mind.
Right.
And people like this gentleman, this colleague from Egypt, of course, I think that type of participation on an international level is so important.
It is.
And he has some very interesting points. We unfortunately are out of time, or I'd like to continue to address all of this. But if you email me or you email John, or email Tammy, any of us, we will try and dig deeper into this dilemma that you're having, and maybe we can just focus on that in a program here in the near future.
Sure.
So that's another thing that we can do. You have a topic that you'd like to discuss, just go to perfweb.us or perfusioneducation.com. Email us. I think it's contact@perfusioneducation.com. That's it. The email address is contact@perfusioneducation.com. Reach out to us, and we will we look at it all, and we answer it all, and we try to follow up with everything as best we can. So, John, do you want to close us out?
Yeah. One last comment. The students nowadays at most of these perfusion schools, they go on to different rotations where they're under different perfusion staff and different perfusion experienced people, and they're told slightly different things at different places. They go on 3 different rotations. They're told one thing in the classroom, then they go do a rotation, and they might be told a little something different there. They go to the next one, they've told maybe even the opposite about something there, and the third thing, and they come back to the school, and they may be kind of a little bit shy or embarrassed about, hey, I heard different things than what you're testing us on, what you're teaching. They could come to our forum here and get our opinion about, I worked at so-and-so and I was told this, but then I went somewhere else and I was told that. What do you guys think about that? We would probably have a great discussion about why people would treat something 2 different ways, and the student could probably really teach us some stuff as well.
And there could be a very good reason why these people view it one way, these people view it another way. That is the whole point of the art of medicine. Even though we have hard science, there's a lot within the hard science is a lot of nuance.
Absolutely.
Right, and I think that's what would happen. We wouldn't pick one that was right and one that was wrong. I think we would find the pros and cons in each of the things that the student was bringing up, and that would just be fantastic.
Correct. Okay, with that said, I'm going to bid everyone adieu. David, are we ready to call this day? Call it a
Ends the program?
A wrap. Call it a wrap. Are we going to call it a wrap? All right. We'll see you all April 14th. Don't forget, April 14th through the 17th, MediWeb Spring Conference. Sign up for it if you're a what do they call it? Unlimited plan. The program is all part of the unlimited. If you're not, it's a very affordable way to get 26.2 CEUs from the comfort of your home, your office, whatever it may be. And we look forward to seeing you on the 14th. Thank you all, and good day.
Bye-bye.